A very good morning to all delegates, speakers, and everyone present here. I am Vishnu, and I welcome you all to Foryensicon 2025 Day 2. So, what do we have yesterday? Yesterday we had a series of 4 different guest speeches, which were very knowledgeable and thought-provoking as well. So today we have many more sessions coming up, and I hope you're all as excited as I am. So I would like to call upon Dr. Parinita S. Naik, who is an assistant professor in the Department of Forensic Medicine from AJ Institute of Medical Sciences, and Dr. Veena J.S., who is also an assistant professor in the Department of Forensic Medicine from PhD Institute of Medical Sciences and Research, Coimbatore. We welcome you, ma'am. I would now request the chairpersons to join me in welcoming Dr. Veena Vaswani ma'am, who is the director of the Center for Ethics, Day2 University, and who is also a professor in the Department of Forensic Medicine in Yanapaya Medical College. We welcome you, ma'am.
Good morning, all. We have a session which is very, very important in today's context. Our topic is LGBTQIA, medico-legal issues in acceptance and otherification. Our resource person is Dr. Veena Vaswani ma'am, who is professor in the Department of Forensic Medicine and Toxicology, who is also director, Center for Ethics, Yanapaya University, Mangalore. Actually, a lot to read regarding her profile, areas of expertise, and academic contributions, awards and recognition. We will need another session for that, so I am moving on to her. Over to you, ma'am.
Good morning to you all.
Good morning, ma'am.
Can you hear me? I think I am hearing myself too loud, so I should be okay. So seeing is no problem because I'm not under behind the podium. So good morning. I would like to start by saying what I am saying is not a rocket science, nothing new to you. Then what I'm here for? I'm just trying to crystallize certain perceptions that have resulted in our betterment of medico-legal service to understanding communities like transgender people, and also to explore philosophically why the injustice is caused because of what I call a social epistemic injustice. So these are some critical philosophical thoughts that also wrapped around medico-legal things. I'm not going to rattle out the medico-legal sections, BNS, IPC, which you are very well read. Plus, we have help from our whole Kerala experts, Dr. Nagesh and our colleagues, legals, and our Kishore also here. So all of them. But my approach is first philosophical, getting into the thought of what is otherification, how does it happen? And to be humane, we should look beyond binary. Do we have any transgender close friends here amongst us? Can I have a show of hands? Yeah. Yes. So he's not raising his hand, Kishore. So, yeah, so we need to know that when you know a person, through the person, you get a lived experience of people. So that is why I took that. Now can I have, it takes 5 minutes for you to scan this. Would you be able to do it? If you're not interested, fine, but if you are, you could scan it and then you could try to fill out. Because this is a brief survey, it is never ever going to be published, it is just for understanding the perceptions, and it's only for educational purpose to tailor the session of participants' needs, because further we can decide how to reinforce our concepts. They're all anonymous, and in no way it assesses the educational thing, but it's only about perceptions. Yeah. For those who came in, we just have put a scan here. You could scan it if you are okay with answering a couple of questions. This is not research and this is no go publication. It is just for us to understand, to build a better sessions over a period of time. Varsha finished? Okay. So are you done? It finished? Okay. If you have finished, then I could continue. I could just get a cue from you that you have finished. So can we start? Here we are going to talk about intersection of gender, sexuality and laws in forensic context. So that too I am using the lens of philosophy through epistemology, and the key focus is acceptance versus otherification. And then the relevance in forensic medicine and ethics. Importantly, because if we who are the leaders of change don't believe and focus on the changing strata of gender and get acquainted and accept it, then we also might be in the peril of bringing injustice. And structural procedural barriers for LGBTQIA persons. Now this is, we are going to wear the shoes of them, try to look at from empathy perspective as well as knowing on the other side, because for that we need to have lived experiences being spoken by them and implications for practice and policy in India. Because this morning when I told, I had invited a couple of our transgender friends, they said if you start at 9:30 we can't, our day starts much later. So I said I understand, so I could not bring them. But we do work with a community of transgender persons for our past 3-4 years. We have non-agenda meetings with them just to find out how they are doing, and to each one's professional or personal life where help is required, we try to give them, be it healthcare, education and career and whatever they need to do. So these are certain terminologies. I'll quickly go through it. I will not think that it would be assumptions that okay, we all are on the same page. So lesbians are women who are emotionally, romantically, sexually attracted to other women. And whenever we talk of these terms, we should ask ourselves, do we have a bias? Are we thinking of this term as a term, or are we already attaching certain evaluation component to it? If we are doing that, then there is a huge bias which we carry. So if they are to receive justice, we may not do justice to them. So the gay is a person typically emotionally, romantically or sexually attracted to people of the same gender. So they could broadly refer to homosexuality regardless of gender. So gay sometimes goes even with the females, it's not necessarily the lesbian is the only word. So bisexual, a person who is emotionally, romantically, sexually attracted to one or more gender. So not necessarily at the same time, but they could be in relation with one person or over a period of time with another gender. So, and transgender is a person whose gender is different when he was born, or who does not conform to the gender assigned to him or her at birth. So there is a difference with the gender that was assigned and the person what he is. So that becomes a transgender, and then they may choose or not choose to undergo a change, because we have one community in Mangalore with Sahaj Parivartan. They don't believe in undergoing the change either by breast augmentation or whatever to suit the gender, but they feel their feelings should be respected enough. So they might call themselves transgender female, but they could still have a mustache. So now queer is an umbrella term used to describe sexual and gender identities, and not just heterosexual or cisgender. So they reclaimed from a slur. Initially we used to look at queer as a slur word, like once upon a time we thought lunatic is a slur word. It still is, but queer now has been promoted to a word with dignity. It is used symbolically everywhere, and it doesn't mean that there is any negativity attached to queer, in an affirming self-positive way. Intersex, a person with both physical sexual characters, genitalia, chromosomes, hormones that do not fit the typical binary definition of male or female. So it's a natural biological variation and of the gender identity. Then is asexual. They are also called ally. So here when we talk of asexual, a person who experiences little or no sexual attraction in some versions, and the supportive person who is not LGBTQIA. He might support, but he advocates their rights and inclusion. So many times we look at allies and we think, oh, maybe he's also, because that is again our way of thinking about others. And then is plus and minus. This is usually, it represents additional sexual orientation, gender identities and expressions. Some people think there are more than 56 spectrums of gender identity. It is still not able to define. So when we look at male, female, we can also think that we are leaving a lot of voices unheard. They are like below the carpet. We don't know them, we classify them male or female. So now interestingly, because certain is a pansexual, demisexual, agender, two-spirit, gender fluid, etc. Now when I am talking about sexuality and gender, I would also like us to know what is two-spirit. When we talk of two-spirit, we don't talk of sexuality, we talk of spiritual acceptance of the fact that a person has male and female representation in them and they are treated like gods. So in some of the indigenous communities, they still prefer, like this person I'm showing in the picture. So this is two-spirit identity. They are called on to perform tasks of both male and female. Accordingly they have to dress and go. But there is not a negativity attached because they are both genders. In fact, if you look at, when we look at Ardhanari Nateshwara, we still worship them. But then we also have a dichotomy of who we worship, but same time we don't have people with the same attributes, we don't take them near us. So that is why, in fact, when you say Adi Para Shakti, so this Shakti is a female symbol and Shiva is the Shiva, the strength symbol. So there is a combination of both, and that must be realized, and in some people it does represent in a way. So this is to do with cultural dimension of two-spirit people. So, and it acknowledges ongoing evolution of identity and inclusion. At no point we should feel we have a command over identity because we can decide who is male and who is female, but there is still a spectrum that causes a question. So as we have heard of the gingerbread man story, this is something expressed as a genderbread person. Gender expression is often linked to characteristics and attributes associated with masculinity and femininity. Now, if you look at brain, this is what decides the gender. Unlike external genitalia, which we interpret as gender. That is sex, but the gender is in the brain. In the heart is our orientation. Who am I attracted to? And reciprocating the attraction by another person, that decides your sexual orientation. And sex is again when it comes to external genitalia, which is used to give us a particular sex, which is believed that the sex and gender are same. But in many there is an incongruency, and that is how we have different spectrum that we need to be aware of. So when you talk of sex, you talk of sex intersex, that's male, female and intersex. When you talk of gender, male, female and queer. When we talk of orientation, male, female and bisexual. When we talk of expression, male, female and androgynous. Now what images come to your mind when we look at transgender? We generally, first things first, we think they're commercial sex workers or sex workers or beggars. Am I right? Can I have a show of hands? The moment we think of transgender, we think of on the roadside begging. Yeah? But how many of us think that they could be doctors, they're police inspectors, they're police constables, they're in different places? The imagery is formed by us. It is not their fault. We see them more acutely because they are there. But it's something that we have to question our stereotype. Are we imagining them only to be in that? Then we are giving them respect lesser than for an individual. Actually, the one you see there in the family, that's also a transgender, adopted children. But they are a happy family. But in India, less than 10% parents adopt the children, they have their own children thrown out of the house and they don't accept them as their own if they are transgender. In fact, not only thrown out, but it's a very sorry state. When they go back home, they take their money, accept, but then they don't invite them for marriage. And then other things that happen in the house. So they are in the pavements because we have left them there, we have stigmatized, we have discriminated, we have shamed them, we have disowned them. And without safety net of a social security, they are in the stigma and discrimination cycle. But it's a nice thing to know of late, the state is giving a security. If they register themselves as transgender, but that is not enough. Because like we said, there's too much to go around and too few of a resource. They end up getting, I think Tamil Nadu gets them 3,000 rupees and in Karnataka they get only 1,000. So stigma refers to any negative attribute which elicits a kind of response which is not good. It marks a person as differentially valued. A stigma is a mark, but some marks like beauty mark enhances beauty. But stigma is that mark which de-evaluates a person. So it's particularly in circumstances, a person has a diminished confidence because of that. A value that is given to him. From a whole, he gets reduced to a part, he or she. So Goffman, who is one of the great scientists of stigma discrimination, says that all you need to do is to identify a trait and say this is not us. And there's a huge xenophobia against a culture, against caste, against everything. It takes so little to divide people, but it takes a huge amount of effort to unite people. So stigma refers to any attribute trait disorder that makes an individual unacceptably different from normal people. He, then us. One of the philosopher, Emmanuel Levinas, says, when there's a knock on the door, you open the door. Who do you see? Do you see somebody like you? Then fine, you say, come in, come in. You see somebody who you don't know and you have a stereotype image of this person not being good, then you close the door. That is otherification. Immediately you have decided he's not good. But what is your experience based on? Somebody told us. So we have to question our knowledge. What are the sources of knowledge, which is called epistemology? How did I get this knowledge? What is the origin of knowledge? It's given to me by my senses. But can everything be experienced by senses? And some of them are given to us by elders. Is it always correct? And some of them through culture. Is it always right? Hating a particular community, disliking a community, making loud noises about somebody. One time it must have happened, but is it everyday affair? So this is what we should question our own knowledge bearing as to how is it stereotyping and causing a bias in us. So discrimination is unjust or prejudicial treatment of different categories of people, grounds of race, age and sex. And we find many a times they are used to exclude, not to include. It happened right way with German concentration camps, but we have never learnt a lesson. It still begins discrimination one way or the other. Either it is caste, either it's religion, it is a region, linguistic basis, but it goes on. So that's going back to Goffman. You just put a stigma on somebody and then you will make sure you don't remain united. So the multi-layered process of stigma discrimination, which indignifies, first labeling, you call them like somebody else, they are like that, you know, avaru hagene. That means we have decided a girl who is raped, oh, she has low character, loose character. This is one of the most common stereotypes. So this is how it began. We label the person, and stereotyping, link between labeled person and social characteristics. Why? Because she went out at night. So everyone who goes out at night, bad character. They shouldn't be seen. I mean, over a period of time, the patriarchy, which is rooted in the strong assumption of females' behavior and not of males' aggression. Then the third label is separation, because you think, like you say, they have to be separate. When we talk of a particular colonies, communities, castes, they stay here. You know, in the earlier time we have the onis, which are like gullies, where this particular caste stays here, this particular caste stays here. What is it because of? And then emotional reaction when you see them. Why did they come? We didn't invite them. So it's a kind of otherification that culminates into discrimination, which associated with concrete behaviors like exclusion, rejection, devaluation at a societal level. This is what we learned from the transgender people during COVID times. When COVID happened and there was everybody was locked in, did they get their kits? No. Why didn't their kids? Because their Aadhaar card showed them as male, they were as females. So the people who came to deliver said, you are not the person. So did they get vaccines? Yeah, they got vaccines because they were forced to get vaccine, but not the second. Why? Because some agent used the phone call, and so second time they had to go to the same person. That could not happen. So many times we see we deprive. And how would we know what happened to them unless we talk to them, sit with them and discuss through the lived experience of people? So the legal context in India is decriminalization of homosexuality, 377. So this was this Navtej Singh Johar case versus Union of India. It was, you could say, a landmark case decision which gave a victory for the LGBTQ, regardless of their, because it affirmed that fundamental rights of male, female, LGBTQIA, including intersex, all spectrum, have equal privacy, dignity. So otherwise what would happen? Even the transgender people on the road could be arrested for soliciting sex. So the transgender person protection right was a positive act. In fact, in one of the bioethics meeting in Qatar, somebody even mentioned that India is very progressive with Transgender Protection Act. Whereas when it comes into an act, there is a difference between how it works out. Because they said 1% of jobs should be reserved in every places, including police. So I too took a bunch of transgender people to police commissioner, and he looked at me and he said, let them go out. I said, why? No, I want to discuss with you. I said, so it would be nice because we are putting together something. So I don't want them to feel that we are planning something against them. Then he said, okay, we can give them jobs. We can try to, provided you give a good conduct certificate. I said, no. Do you take it from everybody? You don't. Then why do you want only from transgender? The whole idea of the act is to cause equality, and we are still trying to cause inequality amongst equality. And second, you are asking them for the stay, accommodation contract. One room, 10 people stay. The same contract doesn't hold good for everybody. They don't have individual houses like their parents. So there is a difference between the cup and the lip. But good that there is a cup. Now we should think how to get it to the lip. So gaps in enforcement. So criminalization, decriminalization, it's good that it became decriminalized, homosexuality, because with this case, it also affirmed the LGBTQ rights, and the curriculum, especially National Medical Council, directed removal of biased content. Initially, in Tamil Nadu, also there was a conversation of the child at birth if there was a ambiguity. But then there was one particular case with one of he's an invited faculty transgender to I forget his name. So he came. They had a case. in the High Court that no child should be converted at birth in case of ambiguity. Let the child come to teens and decide what gender a person would like to, and then accordingly we should do it. Otherwise, many a times conversion at birth, again reconversion, it just goes on, gender affirming surgeries go back and forth. So that was a very landmark judgment as well. And in the conversion therapy, especially the outlawed what is a conversion therapy? Thinking that transgender or lesbian gays are mentally ill. So you try to treat them. It was Brenner in Johns Hopkins who started this crazy idea of a twin, and one of them had the penis cauterized by mistake. And then he said, don't worry, I can make anyone into male and female by conversion therapy. What he started as an experiment took a huge evolution, because everybody wanted to do it on others. So anybody who is labeled as homosexual, they used to go for conversion therapy, which was very, very attacking the human rights, fundamental rights of a person's expression, and also unnecessary medical interventions. So especially we need for training, SOP update and sensitivity, because we have transgender people coming to hospital. They feel good. In fact, first time they came, they said long distance they walked. They said, nice, nobody whistled at us. So to us, it was a kind of, we are never whistled to actually, but then if that has to happen to them, you can imagine the lived experiences which are starkly different from where we live. So it's like two worlds apart. So we need to understand their point of view. And also to avoid forced non-consensual therapies and educate clients on psychosocial rights. Discrimination and access to barriers, denial of care for queer and individuals with disabilities. We don't only have a derogatory approach for transgenders, lesbian, gay, homosexual, but even with disabilities. It's called the arrogance of ableism. Because we are able, we look, in fact, I have a hypothetical case I used to discuss with a lot of students beginning. If we have 12 digits, he comes for our tenders interview, would you give the job? They would say, no, only 10 should be okay, 12 they would have a problem carrying files. I mean, this is actually the response. So we should think of what is our take on ableism, and are we in a position to think what a physically challenged person can or cannot do by hypothetically constructing situations. I may have 10 fingers, but I may refuse to take a file because I am very lazy. So how does that account for it? But can we exclude them into any jobs at all? So why gender matters in forensic is because of the misclassification of identity in ML and autopsies. The person who's giving the history will give the gender, and we are looking at sexuality particulars, and then we would say, okay, this is not it. So this, and secondly, ethical dilemmas in examination, custody and mental health care. When you are examining, there's a discord, what you feel you're seeing, and you want it to be, I have examined this, but it's also good to the gender given by the person, because gender is a person's individual choice. And then you can say gender given by the person is this, examination you have found this. So exclusion of gender diverse individuals from equitable care and justice. Many a times when you don't tick mark male or female or just transgender, they may not get the same insurance and other related benefits if it is a part of social setup, because then they ask them, go and get the certificate. It's getting certification is another headache. Maybe some other time we should be able to discuss. So key areas where gender intersects forensic medicine is in medico-legal cases when we are writing male female. So misgender, transgender to non-binary persons, it violates their dignity and rights. Secondly is a entity called dead naming. What is dead naming? Supposing my name is Raj, and at 20 I do a lot of efforts to change my name and gender. I become Rajani, and then I'm famous as somebody, and later on somebody announces that, oh Raj, you are here, come here, and then all my colleagues look at me, Raj? So this is somewhere, it's called dead naming. So if they are using that particular name and they are showing documents to that name, so we should be true to that. But maybe in your notes you could always add that the earlier name before they made a transition was this. And IPC section 375, 376 assume male perpetrator and a female survivor of binary when we do sexual assault examination. Trans or non-binary survivors face denial of MLCs or misclassification. Now even today with the BNA 63 in order, it's still binary. Whereas the Transgender Persons Act, after section 18 gives them some scope for who endanger the dignity to be punished with 2 years imprisonment. That means rape on transgender effectively is just 2 years. And the examiner should adopt a trauma-informed, gender-affirming protocol. So this is somewhere we need to rethink about how do we do a trauma-informed protocol and a gender-informed protocol. That means we need to relook at the protocols that we are doing. Because gender-affirming trauma-informed protocol will be a range of social, psychosocial, medical supports gender diverse individuals to align to their physical characters. This is personalized and can include hormone therapy, surgeries and mental health support. But there is no one size fits all. You cannot prescribe this CT all for everybody as the same thing, because it is first understanding the trauma stressors and then to compassion and the dependability. Whether there is a cultural understanding of what they are going through, because the other day, I think Kishore you were there last time, when a boy from an engineering college, when transitioned into a female, was thrown out of the college on the roads, parents disowned. And so this person comes and says, we need some help, we need to do something. So when every system which is supposed to take care kicks them out, then there need to be a place where they are given some response, safety and stability, whether we have a establishment of a safe homes, collaboration and empowerment, because ultimately we may give them a space to stay, but how do we empower? How do we empower them to be responsible citizens in society, and resilience and recovery? These are the 6 core principles of trauma-informed care, and it is not just acute trauma. We are talking about a chronic lived-in trauma over a period of time. So that, like exploitations in childhood, incestuous relationship or a rape, and then when they survive, when they go for a long time, it becomes a post-traumatic stress and it stops them from human flourishing. So custodial injuries, how much time do I have? 50 minutes. Okay, thank you. Custodial injuries and forensic psychiatry, especially when it August 2024, last year, there was a transgender person in Tamil Nadu. She went there in search of a new life for herself. The moment she landed there, the police arrested and he sexually assaulted her. She went to register a complaint. So another police officer assaulted. Then when a complaint was registered, they put her in a, instead of giving her a safe home, they put her in a temporary cell. The warden of the cell showed lot of interest in her. She thought such a kind person, but he came at night and again assaulted her. When she complained about this, they did not believe. They said she is just going on complaining about people. How is it possible in 3 days she is assaulted by 3 people sexually? But then the CCTV camera said that. So then she said there was a lot of media attention. Then suddenly everybody wanted to protect her. So the question is, how much trauma does it take for a person to have even a simple FIR lodged and a safe place where they can stay without being re-victimized every step? So that is something we need to consider. So denial of gender affirming care, increased risk of violence, and we should document the custodial injury, the patterns, and including we should have some sensitivity to it. During the post-mortem examination, misidentification of gender in death certificate and autopsy report can effectively violate the deceased identity, cause distress to families, and cause complicate legal proceedings as well. So best practice both include lived gender and biological findings wherever relevant. If she is living with a gender, that also should be written, and also the biological findings that go hand in hand. So medico-legal challenges is informed consent process, gender affirming care access, post-mortem custodial violence and processes, and denial of consent, survivor examination, especially when it comes to misgendering. In fact, during COVID times, the people who went to doctors, they said, the doctor said, let us examine your genitals. They said, what for? No, just out of interest. But my question is, isn't that an indignity to the person? Are we not objectivizing a person? So where is the human dignity? Because they are transgenders, and can we tell them anything which we do not have right to talk to the cisgenders about? So we need to have some sensitivity and legal identity mismatches when it comes to whenever we are giving them in the earlier names or whatever, because we insist on giving whatever is on the ID and not what they are saying. But if the ID says they are males, if they are saying they are females, I would say we can quote the ID to say male, we can also write gender wise the person has accepted to be a female. Some people don't like to be written as transgender female, write them female, but in your own notes when you're called to give an evidence, you can say it's a transgender female, she came with this group, and the context can be highlighted. And legal identity mismatches and lack of gender neutral documentation. So many a times this is where even as a student, as a postgraduate, we noticed the moment we are doing sexual assault examination, it was like a biblical thing to you have to write she's used to sexual intercourse, and then secondly the fact that she is used to sexual intercourse, and especially if the hymen is torn or not torn in relation to that. But today the whole sexual assault exam is not on the proof what you get. Initially we said single live spermatozoa has to be a proof of rape. Says who? Because the whole definition of rape revolves not only on a penile insertion. So that is where we need to have a more focus and sensitivity. But if you go with the history, alleged history of sexual assault, how many of you agree to the word alleged to be used? But do we really need to use it? If you say she gives a history, then you are not confirming or you are not affirming. But the history given, why should you write alleged? Who is alleging? Am I alleging? So I think this is where the human dignity given to a person who is giving a history is taken away. I don't know if I am hypersensitive about certain issues because people have told me I am, so I want to bring it to discussion also, giving due discount for that. Should we really give a person as an alleged history of everything? Allege, right from history, as a history, you are a neutral person, but when you say alleged, you are no more a neutral person. You are already alleging something. So I think we should put the history given by the person. Okay. So concept of otherification, conditional acceptance and clinical settings, pathologization and voyeurism. Another interesting aspect of otherification, we want to pry into their lives. What are they doing? How are they living? If you're doing that, fine, but do it with an aim of solidarity. Do it with the aim where you can help them. Instead of trying to pry into, have an in-depth interview to discuss. You can have in-depth interview even without a research protocol where you don't have to publish it, but I want to be a friend to somebody, I want to know. We have had nearly 15 meetings with transgender people. Now we have decided to have a cluster small meeting. Those who are wanting to do 12th, they are different, and those who want to some career or beauty line, they are different. So that is how we choose to do it. We have lot of interviews, talk to them, but it's not necessary to publish. In fact, last meeting in nursing college in Manipal, they asked me the same thing, why don't you publish? Because I said I don't do it as a research. They are not research participants, I do it as a humanity. So I will not publish, but I am there to help them when it requires. If I make a research proposal, it will go through IRB. But this is not a research proposal, this is just for the expanding my own knowledge about these things. So structural violence and injustice. So forensic ethical dimensions, how do we balance duty of care and legal compliance? Yesterday we had at length discussion to medico-legal, report not report, but at the same time when law requires, there is no shortcut. Then what difference can we make? Wherever what is required to be done. If they are not getting medicines, if they are not able to access certain government structures, we can be the leaders of change, help them access it. And if there is a sexual assault, I think these days they get 3 lakhs or something. So if there is a delay in those processes and clarification, we can be those leaders. It doesn't mean that we break the law. The law has to be respected, but the care also should be given. Confidentiality breaches and mandatory reporting. So mandatory reporting has to be done. There is no looking back on that. Whereas what we can make sure, we don't breach confidentiality. We don't talk about this at length to different people so that the person is identified and they have a kind of indignity to that. Handling bias in death investigation. Many a times when we approach, especially at the beginning level of the career, we all want to play Sherlock Holmes. So we all want to give cause of death even before starting the autopsy, looking at external examination. Then we carry something, and there's one funny incident I'd like to quote during one exams, that the body was just brought in and it was raining heavily, so when the autopsy started, the examiners came in and they asked what is the cause of death. So they were expecting to be said that I have not yet done autopsies. Drowning. How do you know it's done? Body is wet, clothes are wet. So this is what happens to jumping to conclusion even before we have done complete thorough examination. So a role of forensics responsibility is gender identity, respectfully avoid unnecessary questions about sex characteristics. What I mean necessary, I don't mean examination, but where, what, how you did it, how you became transgender, who are you attracted to, because some of the transgender people say that is very hurting to them. Use inclusive, non-stigmatizing language and advocate reforms. Ethical principles we have to uphold is autonomy of the person who declares his identity. When in question, we write our own observation, what we want to for ourselves, but he is declaring the identity. Justice, ensure equal treatment, and confidentiality, protect the identity in sensitive cases. Implications in practice, update MLC formats, go beyond non-binary, use preferred pronouns and names. It's good to ask what pronouns would you like to use. Train forensic and healthcare staff and advocate in inclusive forms. Key considerations, especially self-identified gender, that is what should be asked, and don't assume gender identity based on their external characters. Reflect self-identified gender, the medico-legal forms also, how they identify this gender, self-identified by the person. Explain procedures clearly and ensure person feels safe and autonomous, and obtain separate informed consent for each component of exam, especially for sample collection, for photography and things. It's better to take when you are doing for sample collection, which is not just for external examination. And procedures in sexual assault cases, again, when we look at 63 BNS, and the definition is quite expansive, but it is still binary. Respect survivors' gender identity and use neutral language. Sorry. So rape of transgender lady, rape laws in India are not gender neutral, and rape of men and transgender person is almost non-offense. Men will be able to find relief in section 114 and 15 of BNS that deals with grievous hurt under this section, and the term of imprisonment extend up to 7, whereas transgender community can find relief under the section 18 of the Transgender Protection Act. But then the punishment is only for 2 years. So death investigation, and I think I'm finishing, right? Yeah. So I think I'll come to the end. Conclusion and way forward. Meaningful inclusion requires then policy. It demands paradigm shift in ethics, practice and legal interpretation, and most of all the belief that transgender, lesbians, gay, homo, hetero, all kind of binaries are us. We have solidarity with them, and there is no us and them, but we are in it together. And let's move from the tokenistic gestures to systemic justice in medical legal systems. Thank you very much.
Thank you, madam, for in-depth insight into this matter. Any questions from the audience?
Regarding certification of transgender, we had a couple of cases wherein we were told that it has to be certification of transgender. It has to be through the executive magistrate.
Executive magistrate. They have a health committees. We don't. But in our reports, medico-legal reports, we need to write about the gender which they want to be expressed.
certification as such.
No, certification is by the authority, legal authority that they have set, including the plastic surgeon is one of them, and that's only after they have undergone a surgery. So many of them say we don't want to make any changes, we want to be like this, then they are not getting a certificate. So that is a problem.
Doctors.
No, we don't give, we don't have a role. Only if you do kind of surgeries that are like they do a breast enhancement and so on, you give that you have done these surgeries. With those surgeries they go before the district magistrate. There's a committee set up and then they're given the certificate. Yeah.
Most of the hospitals, when the patients comes to the hospital for registration, most of the hospital they will be having only two options, the male, female. If a transgender person comes, so if there are only two options, online registration,
I think it's time we should make the other, and at least put transgender in the other in the meantime. Later on you transgender females or whatever intersex in that.
No ma'am, so yeah, that
we have to make it, sir, because the software is made by us only. We have to make those changes.
So ma'am, right, suppose in the hospital there are only two options. A particular person, he wants to be identified himself as a female, and if the doctor enters that or the clerk enters that one as a male because anatomical sex is male, whether he can sue the hospital for the harm he has suffered, ma'am?
All over the world, the transgender's gender is identify the person.
Yes, ma'am.
So you may want to call him male, female, but if I say that I want to be male, then that counts. So then, because the certification there is much easier, because they don't have this rigmarole of going through. But here also in our hospital, when they come, we bring transgender, they say transgender male, transgender female, they write them a male, female, just transgender somewhere, they'll insert that it is. We also have not totally have a third gender, but we are pressing for it. Yeah.
If it's a manual file, ma'am, if it's a some hospital they have this,
that is right, so that is why this is how we ignore, and that goes back to the epistemology of whoever told us there are only two genders, and what we didn't know, we think it is others, they don't exist, and later on when we come to know, we are happy with these two, we don't want the third one.
Actually,
so that is the hierarchical way of structural thinking.
We have to think like in the statistical point of view also. The whole point of dividing the persons as male, female, transgender person or queer person are for, in a health perspective, it is for the statistical recording. We have to know what is the status of their health and their risk of any diseases. So to ignore that part is a crime actually. So we have to encourage the people and the management to include the terminologies, whatever terminology is possible as the queer community wants to be included.
No, it is not only statistical purpose. Okay, so for example, looks like a male, but wants to identify as a female. Okay, suppose wants to get admitted to like in a ward. Okay, so right now actually we don't have like that the separate ward for them. Suppose if that looks like a male, but she wants as a she. Okay, that now he or she like that one now. But where we should put?
Yeah, so the whole
this is the
thing,
one again the problem arises.
So
Society has to go yet.
So, no, I was thinking when we talk of transgender persons, when we assign them the gender that they want to, then we also should make provisions for the hospital. At least 2 or 3 rooms should be for them.
So we should
because
think in
the
that
first
way also,
step, and actually we will do all that provided NAC wants it. I mean, we are only by, we like a policeman at the elbow type. Somebody is watching us, somebody makes it compulsory, NMC makes it compulsory, we'll make it. So, NABH,
Even,
now whatever.
even
So,
toilets and all those things also like
yes, toilets also for the transgender. It is time, it's not that we don't have money. I don't agree that we don't have money. We have no inclination to include because we are in our own comfort zone. This is fine, we are happy, we are getting most of it. Some minuscule transgender not getting their rights, why should we be bothered? So many times the question does come and stop here. ಎಷ್ಟು ಮಾಡೋದು ಅವರಿಗೆ, we take our buses and give them dental care, what more can we do? That's not the end of it. Have we given them job, have we given them dignity? I keep asking, you want any person to help, let me know, I can get it. Oh, transgender adre bedappa, because we have a stereotyped imagery of every transgender as bad. But I know a huge bunch of them. One lady who became, after she was a boy till 16, her family threw her out 2 lakhs, she's literally from sex work. She's giving to her brother's marriage, and her father says, you don't come for the marriage. You give money outside and go. I mean, this is what she says, I would like to die for others, but I want some dignity for myself. So in that interview when we did, I didn't know whether I shed more tears or they were shedding tears. Because it is the experience is very touching. Yeah. Sorry.
Okay. Related to research, madam. See, many times actually we use this, we have a confusion, okay, whether we should use the word sex or gender.
Yeah.
Which is the ideal, according to you, which is the ideal to, include that?
I have to go to my research question. What is it that I want answered? If I want to know about sensitivity of sexual harassment at workplace, I use the word gender. It is not sex. It's not sexual harassment. It is gender-based harassment. Whereas when it comes to sexualities, expressions of something, then sex is used, which means we are taking what is already given to them. 55 males, 55 females. Gender, we ask them. So generally social science studies, the exploratory studies of qualitative research, they would not have enriched us if they had not done this study. So gender is generally used as a person, how he expresses himself. Sex is used as we find in the documents, driving license male, but then the person may turn out to be transgender female. So yeah.
Okay, thank you.
Thank you. Yeah. So, there's one other person also there. After that, yeah, you can give him. Yeah.
Ma'am, I've noticed that all this on-paper documentation where they mention the sex as male, female and others, is it right to put that category as others? Because it's like male, female, others and the rest. So
yeah.
Is it right or?
No, in fact, when the Transgender Act was welcomed, the court judgment of putting them in the other was not welcome because it made them look like you are somewhere in between. So and even the third gender was not an acceptable term. But till such time that it is accepted, at least we give them some distinction that they don't classified as watertight compartments. Whereas this Akkai Padmashali, who is a transgender activist, she's got the Padma Bhushan. So we also felicitated her here. So she uses the word female. She doesn't say transgender female. She says I'm female. So again it is given to them, but later on in the years to come, we may probably have to split others into different categories. Like transgender male, transgender female, or she just wants to be called a male female, or the spectrum, different spectrums that are emerging now. So yeah.
I practice infectious diseases, so I had a transgender female who came for antiretroviral therapy. So when she inquired to the government to enroll her in ART, there was no such provision. So is there a provision, because I went through the NACO, I couldn't find. So is there any provision where in future transgender female or males can be registered?
We have a national registry for transgender people. We are trying to get so many people's name into it. I think we have about 12 people's name we have registered. So we also have a lawyer with us who will fight for their rights if need be. If there's anybody, you could even refer them to me.
No, for ART, ma'am.
ART,
basically in the ART column, it seems there were only 2 designations, male and female. So she couldn't put her name in the ART list.
But we can always do it through activists. So they can explore, because many a times we are working in already set structures.
Okay.
And this set structure is very patriarchal in nature. Male, female here, transgender nowhere.
Yes.
So but now we need to create space for them and we need to make changes. That is why the discussion of talking about transgender, it's important that beyond forensic, even different fields also are putting their minds to it, so that we should be able to do something positively. Thank you.
Thank you, madam. Thank you.
Due to time concern,
Last time I have been to US. Then I met one fellow.
Answer him.
I met one fellow. His name is Dheeraj. He is from Hyderabad. He asked this question with me that, what is your opinion about me? Then I asked that what? And he told that, he taken to me in Chicago downtown. There is an area, all the people are, there is a difference. I asked one question, he only told with me, wherever I go then, they are saying that I am gay. Gay is the answer. Why, ma'am? Why they are saying gay? The person is a married, I think he look like a male, He was there with me for 2-3 days. He asked me, all are human beings. He taken to me's room. He's actually good. But I gone there one dance bar also in Chicago downtown. There also they're saying that only one word that they're gay.
That's why you don't take your wife, huh? Okay.
No. He was there in my house. There are 2-3 females was there. His person looked like a male. He was always there in between the females.
That many people do that actually.
Why is that?
So the question is when we call somebody, so gay and lesbians is a terminology. So the terminology that we give sometimes, like I said, it's derogatory. I think we should learn to respect person to the highest, and whatever are the attributes, we should not single it out. Even a boy who is walking with a gait, how are you walking like this? It makes them insulted, and that is discrimination. Maybe they are developing certain traits unknowingly, but then the question of picking on them makes them more frustrated. So this is stigmatizing behavior which generally people do practice, and it comes out of stereotyping. We see somebody walking like this, then we make, okay, he's a boy, he's looking like gay character. So this is something that we can avoid, but of late what I find is we are doing most things in the external world, we are doing least things in reflective world, which is our true self. So we really don't know who are our true self because we are most with the virtual land. So we should make it a habit to improve here through reflection. Thank you so much.
Thank you so much, ma'am. Actually, in regard to this discussion, I would ask you to watch White Lotus series, in which the same question is there. One person who is a dad, who is a father, tells he comes to know that his father died due to HIV, and why? Because his father used to be MSM, men having sex with men. So he was totally confused and he thought, oh, my dad is gay. Then his uncle corrects him, no, MSM doesn't mean that your dad is gay. Okay. Then his millennial or Gen Z generation kids correct him or question him that do you think your dad is less man or he's femme? Maybe your dad is very distressed about asking grandma to insert something into his anus because he urges for the anal sex. So this is not regarding what a person's identity or what a person's behavior. It is not like that. The person's behavior is way beyond what we conceive, and the exact terminologies we use, we were telling they. We don't know who among the whole people present here identify themselves as queer people or non-queer people, or those who don't want to be identified. We don't know. So we can start using the word cis heteronormative society, always label the community as so and so. We can do like that, I think. And I'll urge the FM community to please urge the FM authors to please remove the words like pseudo-hermaphroditism, hermaphroditism, which were used for lower animals, and please use more scientific. Actually, when I went for one prep training in Delhi, they were actually laughing at FM people because we still use the terminologies. More ethical word is to use persons with intersex variations, while we still use the term disordered sexual development. So please remove such things, and thank you so much, ma'am, for pointing out that alleged history. I usually tell that to my students, so I was so happy to know that from your perspective. Thank you so much.
Thank you, ma'am. This was indeed a very thoughtful, and the delegates might have been instilled with a lot of thoughts and knowledge. I request the chairpersons to felicitate Dr. Veena Vaswani, ma'am, with a certificate and a memento as a token of gratitude and appreciation. Thank you, ma'am. May I now request Dr. Kishore Kumar sir to felicitate the chairpersons with a certificate and a memento as a token of gratitude. Thank you very much, sir. Moving on to our next session, I would love to call upon Dr. Hitesh Shankar, who is the professor and head of the Department of Forensic Medicine from Government Medical College, Manjeri, and Dr. Suraj Shetty, who is the professor and head of the Department of Forensic Medicine and Toxicology from KSACD Medical Academy. I would also like to invite Dr. Ullas Shetty, who will be our guest speaker, who is a professor and head in the Department of Forensic Medicine from EJ Institute of Medical Sciences.
Invite. Hello. Let us start the function. Let us start the session. Yes, Dr. Ullas Shetty, who is currently working as Professor of Forensic Medicine, Head in Forensic Medicine, AG Institute of Medical Science, Mangalore. Your topic is challenges in disability certification and indemnity insurance. And there are there are too many challenges in this disability certification. Disability certificate, I think it is a legal document which is required by the law in various, to deal with various situations. So, there are many scales to evaluate a disability of a person in India and also in WHO. There are too many challenges are there, so there are subjective variation is there. Over to you, sir, to present the disabilities, challenges in the disability and indemnity insurance.
Thank you, sir. Am I audible? Hello? 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 Yes. Is it? Hello? Okay. This is for Veena, madam. So there was a dead body brought to a primary health center. Body was brought from the well. So medical examiner told that cost is drowning. Then the police said, no, sir, it was dry well. Okay, dry drowning. Or madam, it's a joke. Okay, thank you. So, vocal for local, I think I am the biggest beneficiary of vocal for local. The speakers need not come from flight, from Bombay, anything. I think they can be local also. I am the biggest beneficiary. And speakers need not wear all those, but still, I am wearing it. Because this I got in 2008 for my marriage. And I am happy that I am still fitting it.
You will continue to fit in your
This is the only suit I have. So, 10 years back or that, I have given similar topics, disability evaluation in Orofacial National Conference, Plastic Surgery National Conference, as well as Orthopedics National Conference. I have trained more than 250 orthopedicians. I have taken 1.5 hours lecture and the hands-on training for these people, the orthopedicians. Now 10 years later, forensic conference I am here. So I am happy that after 10 years at least, they have recognized me. So yeah, this is my publication which I have done in Indian Journal of Orthopedics, which is very difficult to publish. So challenges in disability certification and indemnity insurance. I am happy that I am serving both dead and living. This is the beauty of clinical forensic medicine. So recent, which I come across, the trending in the Instagram and everything, that the NEET PG was harassed. Then I was saying why she was harassed, because the guidelines which was given was like this: kneeling, crouching, jumping, crawling, okay, anatomy this is there, psychiatry this one, community medicine this one, they have given each one. So you have to fit it to any of the category. For that, board has to assess your disability, and based on these things, and she was unhappy with that. So that is the thing. So again, the discussion is still there, whether people with both hands can do or not. Of course, without head also they can do MBBS, no problem. Okay. Anyway, so the certification, Supreme Court will tell in future, without head also it's okay.
Not brain, not head.
No brain. Okay. So sometimes we get the certification, the challenges here, that lawyers will directly tell, you give this much percent. Okay. Already they have told, okay, you don't have to assess, you have to just give, that's all. So this is the problems faced by us, okay, the lot of pressure. So one of the challenges, core challenges here, ambiguity in legal definitions and assessment protocols, because so many scales are there, like centigrade, Fahrenheit, everything. As sir said, there are a lot of this one, but we can follow the MOHF Government of India guidelines. Okay, ESI is different, workman compensation is different. I think those who are working in those area, they have to familiar in that one. But for us, other people, I think Government of India guideline 2024, 2001, 2018 and 2024. Now 24 guidelines we can follow. So inadequate training, this was when I came to Mangalore in 2009. The doctors in our hospital were facing this problem. They don't want to go to court. Second thing, they don't know how to assess the disability. So this challenge was given to me by my HOD. Then I took it. Then when I took it, how to do, I also don't know. Because in our forensic curriculum, it was not there. So then I got some books, then I studied, then slowly I developed on these things. The threat of litigation, harassment, issuing rejection certificate. If you don't issue, okay, they may threaten you. We will not send patient to you. Okay. Or if you harassment and litigation, this was the one problem we faced. We gave a certificate to one of the patient who is a lawyer. Then he took the certificate, got the compensation in MEC court, and then finally he, litigation was done by him against the doctor, saying that disability is this person. He only agreed. So he took the certificate for compensation. Then for negligence case harassment, he has done that. Then he lost the case, of course, in consumer court. But this was an eye opener for us. If you give disability, there is also same certificate they will take and sue us in the court. So that is the problem. There is one case I have encountered because out of my 4,000 disability certificate, one patient sued us for the disability certificate. We have only accepted that there is a disability. Okay. Then we have to bring the experts from Bangalore to come over here Mangalore and say disability is normal, even the same disability will be there, so it is not negligence. So sometimes I see disability, clinician may not see disability. Sometimes clinician see disability, I don't see disability. Then you have to take a central stand. So these are some of the problems. So what is disability? Yeah, a lot of that. Even disability, Oxford dictionary is different, WHO definition is different, community medicine definition is different, so many definitions are there. Okay, simply they are not able to do the work what ordinary people can do due to some impairment. So this is the event usually for our patients. They meet an accident, loss of some injury or limitation, then they will not able to work, then handicap. Oh, these terminals are not there now. Handicap is not there. So these are some of the few references. I reached the 2024 guidelines. I have already put up in the group. You can see it later. Mild, moderate, severe is a classification. Anybody who wants government benefit should have benchmark disability. What is benchmark disability is 40. 40 or more than that is called benchmark disability. Less than that is not considered for government benefits or PG seat or UG seat, whatever it is. No, patient may fake it. Lawyers have tutored the patient. Mean doctor to kanne kaanadilla anta heli, kanne kaanalla. What to do? Okay. So then what to do? Okay, so they will train the patient. Okay, you simply, one of my lawyer is always tell the patients, head injury patients, go and tell the doctor that you can't smell. What he will do? Okay, smell. I don't have any smell. How to test? There is no test for smell here. Okay, he can, if I put a perfume into his mouth or nose, he say no, no doctor, nothing. Okay, like that. So very difficult. Then I have to see, of course, there is an intracranial fossa fracture is there. Okay, cribriform plate fracture is there. Then he might be correct. Otherwise, we can't give. So this is a formula. Of course, calculation is little bit difficult, okay, but not too difficult. Okay, because we have taken MBBS because we didn't like mathematics probably. So that is the reason. And I asked, I trained my interns in this disability. When I asked, simply I asked, okay, you like maths? No, sir. But then when no, some other one I asked, I like maths, but still I took this one. Then you tell me what is sexy, I told. Sorry, really bad, sir. Not every point of sexy. Sexy means, sir, 26, 26, 36. No, not like that. Sexy means 1 by cos c. Secant theta means 1 by cosecant theta. Okay, sin theta means 1 by tan theta, like that. So he forgot the mathematics. Okay, so that is the thing. But it is not that too easy, too difficult. We have a doctor from Bhadravati, Dr. Ramchandra. He has developed an app. You just put the limitations and the functional limitation, everything, it will give the value. But I don't know why it is not popular in the orthopedic society also, they are not promoting him. Okay, this app he has developed 10-15 years back. Still it is not working, people are not using it for a simple calculation because we have forgotten the mathematics. Anyway, simple. So you have to see normal rib, right and left, compare, that's all. Okay, for example here, the wrist joint 140, 160 is enough. Of course you can use goniometer for the restriction of movement. Otherwise clinically also you can assess, goniometer is not required. 120, so 20 degree loss, 20 divided by 160 into 100, that means 12.5%. And 5 degree loss there, then 5 divided by 55, that means 9%. So then you have to take the mean value, 11%. Okay, these are some of my patients. Okay, for example, you see wrist, the elbow here, 50% loss. Then the muscle strength, okay, you can say wrist 4 by 5, then 4 means 20%, okay. 0 to 5 grading, the MR scoring is there, okay, UK government scale. Then normal is 5 by 5, 4 by 5 means 20% loss. Then stability component, mobility, then stability component, then extra points, okay. So these things in this arena you have to check, okay, whether can the patient lift the overhead objects or remove. You ask him to lift his hand and all. Okay. Then touching the nose, whether it's possible or not. With the elbow restriction, he will not able to do this. But he will do like this. He will come forward like this, bend. Okay. That is the idea. So you can give the percentage, maximum 9% for that activity. In that you can assess how much you can give. Okay. Whether 7, 8. Okay, or 5, 4, 3, 2, 1. That is your assessment. That's how some of the subjectivity comes. Then the hand component is there, prehension, sensation. All these things are given in the guidelines. This calculation you have to do because in the guidelines they have given these things. Okay, so strength, prehension, everything is normal. Okay, the extra points again 10% is given for the extra points. Pain, infection, deformity, there is a pain, how do you assess? Okay, pain scale, it's only subjective. But the tenderness is there, that is objective. Okay, that can be assessed. Okay, not more than 10%. So these are the extra points you can give, again maximum 10%. Then mobility component, the lower limbs, again same, hip, knee and ankle, these three are considered. Then again same, lower limb also same format, mobility, stability. Then movement, range of movement and the muscle strength. So knee joint reduced. Then extra these points, stability components, again these 9 points are there. You have to ask the patient to walk, stand on one leg, squat. Okay, these are the things you have to do. And give, if not at all able to squat, then you can give full 10%. Otherwise, you reduce it. Okay, with difficulty is able to sit. Okay, those things you can assess. Then the deformity, extra points. Again, here shortening here, you can give loss of sensation, pain, deformity, complication. Complication means scarring, although lymphedema, all those things superficial, and then deep osteomyelitis and deep complications, non-union. Now coming to hearing. Hearing assessment is also very simple. Just have to do the audiometry. Do the audiometry, they will give the loss of decibels in the hearing. So decibel loss they will give. Then you have to convert that decibel into percentage. That table is given in the book. Okay, that guidelines it is given. So 30 decibel loss means 1% according to the guidelines, 2024 guidelines. And right here, he has lost 96 decibel, almost gone. That means 100% according to percentage formula. Okay, it is there in the book, decibel to percentage. Then, so this is the formula. The percentage of hearing loss is better ear into 5 plus poorer ear divided by 6. So now this patient, even though one ear is 100% lost, still his percentage of disability with respect to hearing is only 18%. Now vision. Vision is also simple. You have to do the acuity of vision, field of vision. That's all. So you assess based on this chart, right eye, left eye. So 6 by 6 or hand movement, counting fingers, okay, perceptual light. So you fit the patient into this chart. So 10%, 20%, 30%. So one eye loss means 30%. Okay, not even 40%. Now field of vision. For example, there the field of vision, one side it is completely gone, right side the patient cannot see. Then the right eye and left eye is normal, it comes to around 20%, okay, not 40%, 20%. The field of vision you have to do if it is only field of vision. So this is only 30% because one eye is lost. Both eyes are lost, okay, 100%. So coming to central nervous system, little bit difficult here. Central nervous system is not that easy. Of course, cranial nerve is there, very simple. Okay, facial nerve paralysis or what, motor killing 20%, sensory 10%, power, okay, 3 by 5. This is of course for the quadriplegia and paraplegia patients. This chart, power, spasticity, reflexes, sensory. Of course, maximum 90% for the paraplegia, tetraplegia, or quadriplegia. Okay, maximum 90%. You can mild, moderate, severe you can do. Okay, 20, 40, 60, or maximum 90%. So bladder involvement again. Of course, all these cases what I do is I take the help of that concerned department. Okay, so head injury is there, I take the help of the neurosurgeon or neurologist. Okay, even psychiatrist for the clinical assessment. When yeah, so these are the, even bladder I take help of urologist. Okay, so ataxia. Again, everything is given in the chart, okay, in the guidelines. You just have to follow that. Okay. Again, for this one, EEG has to be done. For a person who is suffering from epilepsy due to head injury, then EEG has to be done. Okay. More than 10 fits per month, 75%. So these are again some of the other data. Anesthesia. Okay. Dysarthria is there. Or even this one for the lumbar. Okay, fracture. Okay, spine fracture. 15, 30, 35% is there. Just have to fix into some of the category. That's all. Very easy. This is a facial nerve paralysis. Now this is for the stroke patients. You just have to fit here. Okay. Of course, you take the help of the neurosurgeon or neurologist. Okay. MRS, modified ranking scale, 1 to 6 is there. That's all. Very simple. This is just based on the clinical assessment. So stroke or any other neurological disability, motor disability, not functional disability, cognitive disability, this one. Now ideas, this is for the cognitive disability, that is for motor disability. Head injury you have to assess two ways. One, is it purely cognitive or motor? Cognitive means ideas.
Questions can be asked after the session. Please.
Okay. Yeah. So this is for cognitive assessment. Okay. Patient had head injury and he has a cognitive problem. Motor is normal. Okay. Motor is normal. Then this way you can do. Or if it is motor, okay, then you can assess this way also. Okay. So these are the two, this one, but mainly this is for the cognitive assessment. Neuropsychology assessment has to be done. You have to send it to clinical psychologist. Okay. After that, we will do this one. Okay. Self-care into this. Okay. 1 to 0 to 4 scaling is 4 is the highest. Profound. Okay. Mild, moderate, severe, profound. 0 to 4 scaling. Okay. Then lot of questions are there. You have to ask, and based on that, you can give 0 to 4 scale for each one. Each component 0 to 4 scale. Then the global disability means total disability score plus duration of illness score. Okay. 2 to 5 years means, of course, all the disability minimum 6 months time has to be given for the assessment. Okay. Minimum 6 months. Otherwise it is temporary. Okay. For less than 18 years, you can say till the 18 years it becomes that much only. After that you have to reassess again. Okay. So temporary or permanent, that is the thing. Okay. If you think that this is progressive, okay, or non-progressive, okay, whether it can be permanent or temporary, that you have to decide. Now this is the clinical psychology test we have done for the patient. They will give which area. Okay, this patient has left frontotemporal involvement. Okay, left frontotemporal involvement. So she will give. I mean, this adds to our clinical assessment. That's all. Then urology. Okay, this is given by Dr. Lakshman Prabhu. Urology. This guidelines is not there in the what I have sent 2024. Okay, this is not there. So then I have to look into for Urological Society of India 2012 guidelines. After that, they have not come up with their further guidelines. Urethra, bladder, penis, and sexual function, everything they have given. They have classified into 1 to 3, everything. Okay. So the percentage they have given into 10, 20, 30, all those things have been given. So of course you can take help of this one, urologist. Even impotency also is given a percentage. So total impotency due to road traffic accident or any other, this one 30%. 30%. So amputations are totally easy, very easy, no calculation required. You just have to see the our guidelines and give the value. That's all. So this is the value they have given for each percentage. Simple one. Okay. So for example, nose. This is a facial disability. Okay. Nose is gone. That is 10%, that's all, according to guidelines. And tongue is gone 30%, if from the base. Okay, from the base it is gone 30%. If it is from the right side, you can add 10% more, that is 40%. Okay, the right dominant side, again, and 10% you can add extra. So 30 for the thumb loss and 10% for eclavia. So total 40%. Okay, then now coming to facial injuries. Okay, this is not there here. I took a reference from some other this one. So each one, okay, scalp, eyebrows, this has been given. Okay, so you can assess. You can take the help of facial maxillary surgeons or plastic surgeons. And here, once I went to court and told that patient has lost all the front teeth. Okay, 4 teeth have been gone. I said 20% disability. The judge yelled at me. Why 20%? Okay, these teeth can be replaced. No. Okay, I said this is Orofacial Maxillary Surgeons Association guidelines. I met a orofacial maxillary surgeon. Is 1 teeth loss means this percent. Okay, 2, 3, depending on the this one, front to or back. He has given the guidelines which I have, but that is not ratified by the government of India. That is the one problem. And secondly, teeth loss, as the judge said, this can be replaced and you can be normal. Then I said, madam, if limb is lost, we can replace with artificial limb. Then person will be normal. No, not that. So teeth is different, limb is different, she said. Maybe she is right, okay. But then I stopped giving certificate for the teeth loss. But of course, face we can give, okay, depending on the mandible fracture, maxillar fracture, whatever it is. We do give with the help of orofacial maxillary surgeons and the plastic surgeons, okay. So before after photos we put for the patient and then give the disability, okay. This way we involve all the specialists in the case and finally give the opinion, okay. This is how we give the opinion, okay. 25% face, 30% vision, 10% the cranial nerves, okay. And so this is how we give the disability. Now drawback, calculation I already told you what on the mathematics, but of course there is an app, okay. There is a pill for any ill, like that there is an app for everything now. Okay. Now I have to contact Dr. Ramchandra from Bhadravati. He has developed an app. Maybe you people will be very happy to have that app. Okay. Just put the values. It will give you the percentage. Okay. So calculation is difficult. Not entirely objective. This is the major problem. As sir said, if I see a patient, I will say 10%. Okay. Now someone else is, he will say 15%. I think if the same guidelines, 2024 guidelines is followed by all, meticulously followed, then the percentage of variation should not be 5%. If more than that, then there is something wrong with somebody. Okay. Somebody is wrong. Because this percentage variation need not be too much. Okay. At 20% variation cannot be there. Maybe 5% this side, that side can be there. Okay. That is the one problem. But what I do is, I take the opinion of all three. Okay. 3 doctors will be there. Okay. In my case. Okay. One orthopedician, one myself, one other doctor. So 3 doctors, we come which one is best for the patient. Okay. So objectivity, but still objectivity cannot be achieved 100%. There is a problem, amputation and ankylosis. Amputation at the elbow level is 75%. But the ankylosis at the fixed, okay, you can't do anything. This will become almost 80%. Okay. So amputation is more than the ankylosis. Ankylosis is more than the amputation. That is the problem. Okay, according to this, active range is only active range. I say it is head injury, then I will say it is for the whole body. Okay, head injury applies for the whole body, but limbs will not. Limbs, if they say right limb I have given 20%, how much for the whole? Then I will say I don't know, because calculation percentage is not given in the guidelines. Okay, then they will say, Doctor, Alimco is there. Okay, in Alimco, what is Alimco? Then I search. I got a book, Alimco. Alimco published in 1984. Okay, artificial in Jaipur Institute, which has published the guidelines. There, these people are quoting that it is 1/3. 1/3, 1/3, 1/3, 1/3. If you give 30%, they will make it 10. That is, they say. Why? What is the reference? Alimco. Alimco 1984. But it is not valid, because Alimco has never said that if percentage is there, the whole body you have to cut by 1/3. No, it is not there. What they have said is, each joint applies 1/3 to that limb. Elbow joint means 1/3. Wrist joint means 1/3 to that limb, not for the whole body. So this is erroneous conclusion lawyers and judges are propagating. Okay, but there is no formula converted to whole body. Of course, head injury is whole body. Toe movements are not considered. Paraplegic, both are 90%. These are some of the problems. Again, only physical impairment is considered. Okay, the patient suffers psychologically also, that is not considered. Okay, his mental stress, trauma is not considered. Percentage is higher side. Okay, that is already told. Can a patient, I already told, patient can sue you. If you give certificate, that means there is a problem you have already accepted. Okay, patient can, as I told, one of the lawyers sued us. Lawyer is my patient and who sued us. Okay, then we have to fight for a long time. Then we finally won the case. Again, these things are not given. Like some of the splenectomy, not percentage is not given. Okay, or nephrectomy is given. Okay, only 10% is given. Okay, then this colostomy is no percentage is given. Okay, of course it may be reversible later, but still some people may carry long time. Okay, some things this burns. Okay, yeah. So this is a format of certificate given by the government. Okay, where photo has to be fixed, patient, and all has to say. You have to measure, say it is progressive or non-progressive. Okay, temporary or permanent. If reassessment required, how many years later? Okay, how many years later? So all those things has to be mentioned. Okay. Compensation depends on lot of things. This is not our area. This will be decided by the judge. Okay, pen is mightier than sword. So disability, pain, suffering, he will consider all these things. Income, future expense, loss. Most important thing is disability. That's why lawyers will always tell, go and bring a certificate. Go and bring a certificate. Okay, that is the problem. Okay, that's why where we will be under stress. False certificate. Okay, so this is again 234 IPC is there. BNS is there. 234 BNS issuing false certificate. Okay, that can be a problem. You will be punished under 229 BNS. Okay, 229 for perjury issuing So false certification can be there. Some people are there, okay, issuing false certificates. That has to be countered because it will bring a bad name to our whole doctors. This one. That's why we always involve 2-3 people. Okay, a board is in the hospital. We will do that. Okay. Yeah, many of the, like even Bangalore Medical College, Ballari Medical College, professors were suspended because for issuing false disability certificates. Okay. Yeah. So after issuing certificate, you have to go to the court. Okay. Court means you have to have an affidavit like this. Okay. This is the affidavit type. Of course, lawyers will help you to file an affidavit once you do this. Then this is the second page of the affidavit. Okay. This you have to file in the court because chief examination will be over in minutes. Okay. If you do this, otherwise you have to tell chief examination will take long time. So in the court, when you go, because problem with disability is again you have to go to court. There is no other way. That's why people avoid issuing certificate because court is there. Okay. Nowadays, of course, the Adala settlement and all has come, but still the percentage is not reduced significantly. Okay. Most of the cases we have to end up in court. Okay. Then they will submit the affidavit. Okay. What is your qualification? The questions. Okay. So 149 BSA. Okay. Bharatiya Sakshi Adhiniyam says you cannot scandalous questions. But some lawyers are there in Bangalore, okay, asking 45 minutes, 1 hour, okay, all scandalous questions only, okay. So, what is your qualification, expertise? I will say forensic medicine. How do you fit in here, okay? I said that I have issued a certificate, okay. So, that's what they will ask, okay, have you treated the patient? I will say I have not treated the patient, but I have assessed the disability, okay, that's what it is, okay. Then what is the age? Of course, the person who was treated already signed. Okay, in my board of the doctors, the treated doctors are already there, they have signed it. The effect, the next question, age, okay, person old age, it is because of old age, not due to accident, they will say. So all those things you have to deny. What the type of fracture support, comminuted fracture in node. These are some of the frequent questions asked by the lawyers. Okay, and what they do, the lawyers take your certificate and give it to another doctor. Okay, so what questions can be asked? Similarly, or postmortem also. So be careful while issuing. If you give a calculation and anything, there are no questions. Okay, other doctor has to agree only. So with the treatment, yes, you have to say completed because permanent issued means it should be permanent only. Okay, not so within 6 months or 1 year you cannot issue. After that only you have to issue. Okay, treatment taken, delayed, whether due to delayed treatment. Okay, no follow up, you have to assess. How often patient come for follow up, whether physiotherapy taken or not. These are the questions you have to ask, answer in the court. Which guideline you have adopted? 2024. Okay, Ministry of Social Justice and Empowerment, which I already sent. Then whether X-ray taken or not. Okay, whether union, malunion, these are not. Individual variation, yes, agreed. If the lawyer asks whether there is subjective variation can be there, you say yes. How much? Maybe around plus or minus 5% can be there. You agree. Whatever is there, you have to agree on it. Then, do you measure the difficulty in eating? How do you measure? Okay. So, how do you assess this one? You said he cannot squat. How do you say? Oh, he cannot squat. Okay. I said my clinical examination. Okay. Clinical examination. Now, whether partial or total disability. Okay. Total means not able to work at all. Partial means yes, able to do that previous work, but with difficulty. Then ESI workman consider, no, we don't consider this one. This is for the ESI doctors, not for us. Okay. Pain subject, how did you measure the pain? This is a common question. Doctor, if I remove the implant, whether the pain will subside? Okay, maybe, may not be. Okay, but as of now it is there, I have given it. Okay. What is the disability to the whole body? Okay, that is the question. Cost of renal implant, can it be done in free of? Yes, government is free. Compulsory to remove implant, maybe or may not be. Okay, disappear implant, remove, yes. Discharge summary, return, improved, better. Okay, advice for follow-up given or not. So these are the some technical questions. Okay, will be asked. Okay, not regarding your percentage of disability. The questions are always about the procedural aspects. Our court, civil courts are basically procedural courts. Okay, not the scientific way of method assessment. Okay, patient request certificate, why the patient requested, lawyer requested, all those things will be asked. what is the occupation? Have you considered the occupation of the patient? Okay, while assessing the disability. No. We can't see the patient occupation and give certificate. That is the judge to decide, okay, how much his vocation has been affected by the this disability. We can't go on telling what is your occupation. He may tell lie also, okay. So we can't decide on the occupation. We are giving physical disability, okay, or cognitive disability, okay. That's all. Not evocational disability or occupation disability you are not giving. So if disability occupies earning capacity, will ask, okay, whether it will affect, you say yes, okay, depending on the occupation is told to you, okay. Then have you considered occupation analysis here? Do you give fitness? Fitness is already given or not? He is perfectly fit, you have given already once, when you have your follow-up time. Then you give disability later, okay. There is a conflict now, okay. So be careful about this one. Can the patient continue his occupation? This question will be asked. You take a call. Again, I have faced lot of lawyers, okay. 5 states I have gone for the certification, okay. Then most toughest lawyers will always be females, okay. Since I am married, I don't have much problem. Okay. Toughest lawyer is at home only, okay. So this is my wife, so no problem. I am able to, okay. After my marriage, I got a courage now, okay, no problem. And again, once you issue a certificate, people will always be on you, okay, yes people, okay. So, ಆನ ನೀರಾಟದಲ್ಲಿ ಮೀನ ಕಂಡಂಜುವುದೇ ಹೀನ ಮಾನವನ ಬಿಡುನುಡಿಗೆ ಅಂಜುವನೇ ಸರ್ವಜ್ಞಾನ. Means you issue certificate, people always say you are a liar, you are a liar, you are disability, you have given false certificate, false certificate, false. Everybody will think that you have given certificate to get money, earning, okay. People always think of court or whatever it is, okay? But you have a thick skin, brush it off, okay. You follow your ethics and whatever it is, okay. Don't be bothered about people telling, okay, you can't stop at every dog that barks, you will not reach destination, okay. So people will say that he is the one giving certificate and everywhere. Your own colleagues will tell. Who else is required? Professional jousting. Our own colleagues will tell, okay. That guy had one case, okay, he will issue certificate for right and left hand, okay. You develop thick skin, that's all, okay. Don't be bothered, you do your work, okay. Karmanya mafalechu kadacha, okay. Yeah, so people have achieved many things in our life, okay, with the disability also, okay. Don't consider disability. Even I have disability, which you might not see it. Can you see it? No. Can you see now? This is my acting, okay, that's all. Okay, my 6th nerve is gone, okay. But now I have facial paralysis because of my parodidectomy, okay. So still, if X-ray comes, this side, sensation here, okay. No sensation here because of parodidectomy, facial nerve is gone, okay, facial nerve is gone. But earlier I used to think, when I see lot of my patients, these people are suffering so much. What is my disability? Minimal, okay. Singularly one bindu, okay. So that's what it is. So even speech, I am here right in front of you. Earlier, before, okay, I used to be an introvert in English and extrovert in Kannada, okay. I cannot face the audience, okay. But now I am in front of you, okay, cracking. So it's all disability. You have to come out of disability. A lot of people have achieved. Okay, be thankful to God that you are born with this. Okay, minimal disability or no disability. Okay, be thankful to God always. So, ಇರುವ ಭಾಗ್ಯವೇನೆಂದು ಬಾರನೆಂಬುದು ಬಿಡು ಹರುಷಕ್ಕೆ ಇದೇ ದಾರಿ. ಓಕೆ, ಬದುಕು ಜಟಕ ದಂಡಿ ವಿಧಿಯದರ ಸಾಹೇಬ ಮದುವೆಗೋ ಮಸಣಕ್ಕೂ ಅವನ ಕೇಳಿದ ಕಡೆಗೋಡು ಪದ ಕುಸಿಯ ನೆಲವಿಯುವುದು ಅಂತ. ಓಕೆ, so now the next, whether we need insurance or not. This is mostly for the clinicians. Now forensic people, do we need professional indemnity insurance? Take sir. What's it?
Practicing.
Yeah, because I have a senior fraternity from Karnataka who is facing this. Okay, State Medical Council. Okay, he is going n number of time here and there because he has done a postmortem where it was murder case supposed to be. He gave it as natural death or something like that. Okay, to be murder case, and they filed a suit in the this state medical council. This is running since last 10 years. Supposed to go again. Doctor next. Okay, Tariq pe Tariq. Okay, our senior, one of the senior most forensic person of Karnataka. Okay, now if he had taken the indemnity insurance, state medical council expenses could have been covered, lawyer expenses, travel expenses, everything could have been covered. Okay, but having said that, since most of our patients are dead, we may not take. Okay, still okay, maybe forensic people with active into this clinical and all, maybe they have to take it. Okay, but again, this mostly for the clinic. See, it is so costly. Okay, in America you can't without insurance. It's like driving license. You have a car, without driving license you can't drive. Okay, but here like that, indemnity is not there, you can't practice it. It is 20% of your annual income. The premium is 20% of your annual income. You can't pay it initially. Then at the end of care also it may not be able to. So people will drop out of career because not able to pay the premium. Okay, in the Western countries and very difficult. But as of now in India, litigation is very less, so you can afford the premium. When the litigation goes up, you can't pay the premium. Okay, to take alternative career. So any criminal act, of course, insurance of professional indemnity insurances will not cover criminal act, criminal defamation, service and intoxication, procedure outside hospitals like clinics and all if you done, use of miracle drugs, cosmetic surgery, euthanasia, labor disputes will not be covered. High premium. Okay, whole damages they may not pay, lot of running around. Okay, like United is there, Oriental is there. Okay, so many private players are also there. Defense lawyer in the panel, insurance panel lacks medical knowledge. See, most important thing for when you receive a complaint, negligence suit, is that your reply, first reply is the best reply. First reply has to be analyzing everything, giving all the proof. Okay, so first reply has to come from the lawyers don't know anything. Okay, some medical person has to be there. So medico-legal consultants come here. So they have to give the opinion, and then first reply is the best reply. There you have to. Now, when you have an insurance, you say, okay, go to litigation. You file a case, you file. I have insurance. That much courage you will get. Don't go for that. If you negotiation, you go for negotiation. Don't fight it. Okay, because you have insurance, you have the courage now to fight the case. Don't do that. Okay. So policy. Since I am a medical secretary of Association Medical Consultants in Mangalore, having 700 consultants, AMC policy, which I advocate, is 1:1. Okay, this is the one thing you have to look when you buy a policy. Okay, any 1 year or any year of occurrence. That means if you have taken 10 lakhs policy, one incident happens, then 1:1 means full 10 lakhs will be available for you. If it is 1:4 ratio, then only 2.5 lakhs is available for you. That is the problem. So 1:4 policy if you taken, premium is less. That the insurance agent will not tell. If it is 1:1, then you will get the full 10 lakhs cover. So always choose 1:1 cover. Ask the agent what is the AOI-AOO ratio. Okay, if it is 1:1, take it. Okay, so it is covered for the State Medical Council, National Human Rights Commission, Competitive Commission of India for corporate hospitals, out of court settlement, civil and criminal courts, police inquiry are covered. Worldwide coverage. Okay, because medical tourism, people from abroad also will come, then litigation can be there. That is also covered by Association of Medical Consultants. Travel, out of court, lawyer charges, everything is covered. Cashless is there. Medico-legal cell is there. This is important. Okay, the doctors who are filing this first reply, okay, are the medico-legal consultants who have done LLB also. Okay, expert in this field, they will help you to file the first reply. Okay, then the reduction is the retroactive date. Okay, once you take a policy, you did not pay the next premium, then your premium taxes. So last thing will not be covered. So you have to see an instance where retroactive date is available. You have to ask the agent, retroactive date is available or not. Means if tax policy is there, still the previous one is considered or not. Okay. So qualified and unqualified people and the whole nursing home is covered or hospital is covered. Individual policy or hospital policy, two policies are there. So custom cover hospital, This is usually not covered in any of the medical indemnity insurance. Plastics, cosmetic and radiation therapy are not covered, but AMC covers it. Retroactive date is available. Hassle-free cashless run-off cover means when you lapse policy also it is covered. So do not hide previous cases while taking the issue. People usually take health insurance, they avoid hypertension like that. Here also don't hide the previous one. Then do a qualified nurse will be asked to tell yes or no. Keep the policy for long. Don't throw it because policy we throw next year only. This is because a left cesarean left in the abdomen will be detected 10 years later. So policy of that year will be come into picture. So if you don't have the copy, then it's a problem. So keep the copy for at least for 10 years. Okay. Read the document before signing. 1:1 should be there. Now, Dr. Jani has given this one. He has started a company, okay, Cover You, okay, with the IAFM collaboration, all the association coverage, which gives more lucrative offer for the premium and the coverage. Okay, IAFM, that is called Cover You by Dr. C.V. Jani. They cover loss of confidentiality, document loss, run-off, everything is covered. All the facility which I told in AMC also covered in IAFM, that Cover You. Okay, that is also there. They say 80% reduction in premium. We say AMC, we say 50% reduction in the premium. Okay, so this is how the premium looks. Okay, nowadays 1 crore is minimum. All the clinicians 1 crore is minimum because the district consumer redressal forum covers up to 1 crore. Okay, earlier, now it is extended. We have 10 lakhs, then 20 lakhs. Now 1 crore up to 1 crore is taken up by the district forum. That's why we take minimum, because people tendencies go for 1 crore. That's why you have to take 1 crore for all the clinicians. 1 crore is the minimum policy you have to take. You can take nursing home also. Of course, this depends on physician, surgeon, anesthetic, plastic, dermatologist. This is our policy premium chart. Okay, of course. 1 crore is the one. It's not that difficult. Okay, hardly less than the car premium, car insurance, less than the car insurance. IM is offering very beautiful indemnity insurance. I don't know how it covers. Okay, don't know the efficacy. Okay, who is there in the board? But they are very cheap, dead cheap. Okay, maybe you have to look their AOI and AOI ratio 1:1 or 1:4, probably 1:4. So these are my references. The first one, 2024, I have already given to you. So I am thankful to all the people, okay, who have helped me. So I have a house, I built a house recently, okay, which I named as Apagata Nilaya. Because most of my money comes from the accidents. So I made it, okay, and orthopedician I have to make photos. I have made 1 room for orthopedic. This is Dr. Mayur, right? Okay, maximum like that. I will keep the photos of Sunil Shetty, Dinesh Kadam, like all the doctors I have kept 1 room. Okay, contributed by Orthopedic Association of Karnataka, like that. So Pagatanile, because most of my this one is there. Okay, so I am thankful to all the orthopedicians.
Your wife agree?
Yes.
What about Jayprakash? What is the name?
Dr. JP.
What name is for that?
Entrance. Because yes sir. Because he is the one who introduced me to the clinicians. Thank you very much. How much time do we have?
We'll take some 10 minutes of or maybe 5 minutes of discussion. With the floor is now open for discussion. Any questions to the resource person?
One-third Karnataka government High Court has given multiple orders. In Karnataka we follow 1/3.
Yeah, whole body disability. But I always disagree.
No, one thing you should always, when a lawyer asks, you are always directed to court will decide.
Yeah, that only. Because it is ultimately judge has to decide what is the whole body disability and the compensation, how much should be given. Because he has to consider everything before giving this one.
One more thing you should tell that in Karnataka is accepted but not in Kerala. Except for Kalcheri, court accepts accepts, but other court in Kerala doesn't accept private disabilities.
Okay.
Yes. Exactly in Kerala,
They want a medical board.
the client has to submit a application to the superintendent of government hospital, and they will form a board to issue disability certificate, not private persons. And how in Karnataka it is possible, I don't know.
No, even it has gone to High Court and even gone to Supreme Court.
Yes.
It's accepted. Couple of my cases have gone to Supreme Court where they got extra money. When it reaches High Court, it's 50% increase. When it goes to Supreme Court, the law is very clear. It says a medical officer. Only basic MBBS degree is also enough.
But for assessment of disability, as in Indian legal setup, a body has to be constituted.
Body is there, you told, all the conditions.
Yes. In which I am happy to know that a medical consultant is there, because actually it is a forensic business. If one person is disabled, then it is a violation of Article 21, ma'am. So it is the business of forensic person to assess the disability of a person. But in Kerala it is not being recognized. But in Karnataka I am happy to know that it is been recognized here, and Dr. Ullas Shetty is one of the part of this disability board.
Hello.
Yes.
Sir, in one Kundapur one case, this came as around 60% from in 1 week. Argument happened that, at the end, I think they'll put it at Evensegi to the board. If the difference comes, around 20% or 30%, is there anything, they'll punish the doctor who for giving a false certificate or something?
Yeah. For BNS issuing false certificate, punishment is on 229. Okay. But usually it will not happen. What they do is, if there is too much discrepancy, the lawyer and the court can refer it to the board, district board. Every district will have a disability board from the government. They have to take the call and decide and give the report back to the court. Usually punishment will not be proceeded because it's your opinion. Your opinion, in my stance, this is the percentage. But disability board, they have to, if it is same with that, your credibility will be up. If it is too much difference from the disability board and you, then the credibility of you goes down in the court, that's all. Otherwise, usually punishment very unlikely because you don't have a motive.
Sir, Ullas Shetty is very famous with these things, because there is one case from Kundapur, came here, we treated from here. There is one eye is completely blind. We give one percentage of 30%. 30%. And certificate issued from here. Then the lawyer called me and told that you given only 30%. Yeah, that's the maximum what we get. That's already given by Ullas Shetty. Then how the Ullas Shetty given the certificate? That patient is gone somewhere or other hospital, sir. We are thankful for, he is the master of disability. Whenever the case comes, we'll ask Ullas only what we'll do. One more, sir. How much we can charge? Because
yeah, sir. TADA. Okay. So what I do is, if it is Bangalore court, okay, my time will be around 2 hours for my, okay. So I usually charge around 3 for Bangalore patients. If it is Udupi, I have to take half an hour, half day, okay, around 6,000 I will charge, double, okay. If it is Kundapur, 7,000, 8,000, depending on the distance. If it is Medico-legal, sir, I will be at 10,000. So,
last time I had been to Bangalore. I asked 25,000 rupees, but you given only 5,000.
Sir, whole body, sir, one third you have to cut.
Correct.
Dr. Ullas Shetty, this question is usually sometimes encountered in the court of law also, for trial of murder cases. Recently we had one case, Soumya murder case, Soumya Raipan, in which the accused was having one forearm below elbow amputated. And he pushed her out of train and carried her to some other place and raped her and murdered her. And whether he could do this or not? That was a question by the defense lawyer.
Yes, sir.
And so that is usually we have to assess the disability or what is the power of his muscles and power of his to assess in medical legal situation also. It usually comes. The other one also is a medical situation, but in murder cases trial, it usually comes.
Yes, sir. No, I do get lot of cases in murder cases, volitional activities. With a trachea cut, how he can speak, okay? How much time he did he survive? This is the what? Volitional. How much he can do? This many cuts, can he run to that many distance? How many minutes he can? Volitional activity. Similarly, as sir said, whether the elbow is one, of course another may be normal. So he can carry her like this, lift her up, possibility is there. Because we can't say it is not possible. Never say never in forensic. So it is possible. People can do wonders even without limbs also, like Nick Kujisik. Do wonders. Then with one elbow cut, I think another elbow this man can carry and do him rape, murder, whatever it is.
He escaped from jail also.
Yes sir, yes sir. It was in the news, correct.
Sir, since I do this, the audit for some insurance companies, and I have come across numerous disability certificates that have been given by Dr. Ullas Shetty, and in my experience, it's one of the most accurately and very clearly, drafted certificate that I have come across. So, congratulations to the organizers for getting the right person for the right job. It's not actually vocal for local, sir. It was not because you were available easily. It is because you are the right person. Having said that, in my own experience with disability certificates, I have found some inconsistencies with the guidelines, the Ministry of Social Justice guidelines. For example, sir, if you assess the deafness, disability because of your the deafness, then the disability that you get, if you consider it as a cranial nerve injury, it will not cross 10% if it is because of cranial nerve injury. But then if you do it in other routine way, the disability will be definitely more, sir.
Yeah,
that is one inconsistency that I always
no, guidelines is clear. Hearing and vision is not cranial nerve. That is separate guidelines is there. You have to follow that one, not the cranial nerve guidelines.
Yeah, but then if it is because of head injury, the cranial nerve injury, then we don't know which one to follow, sir. I don't think.
No, follow the audiometry way only.
Yeah.
Not
because then definitely it will be beneficial for the
patient.
patient.
Yeah, definitely.
Yes, sir.
Sir, one more doubt, sir. Whenever we are receiving that summons, there are two options are there. One, either we have to attend the court, or we can call for a court commission, isn't it? Or third one is a video conference. Is the video conferencing available?
Civil courts, civil cases, not much. But if it is far off places, they can do. It is all the judge's take. He can allow anyway. Some people like in Bhatkal, the judge is so much good.
This is the civil cases.
Only local they may not allow, but all other outside places, the VC can always be allowed. Civil or criminal, whatever it is.
Sir, one more thing. Which is the better one, sir? Shall we attend the court or court commission has to come? What is your opinion?
It depends on you. Court commission can, if you are not, want to go out, like Medico-legal source place, then
court commission.
You tell them to come here. Okay. You want to travel or not?
Sure. Thank you.
Sir, most commonly outside Mangalore, beyond Kundapura, it is court commission. Here, even Puttur courts and Madikeri courts, they are ready for court commissions.
Okay. Sir. Yes. Yes. Yeah. There are two ways in cardiorespiratory system wise. One is chest expansion. Okay, less than 4 centimeters is called severe disability. 1 centimeter, 2 centimeter, 20, 40, 60% disability is there. The guidelines which I have sent, it is there. So one chest expansion. Second is breath count. If you have to tell them 40 words in 1 minute, then it's okay. Other count, okay, count of number count, 40, okay, is the cutoff. If less than that, you can't tell in one breath, okay, one breath, you can't tell 40, okay, 1, 2, 3, 4, 5, 6, 7, 40, you cannot tell, then it is percentage is given in that book which I have sent you, okay. So 20, 40, 60, 80, it is there, just see that one, it's easy. Yes, that is cardiac also. Again, the steps, there is this one, in that book only, cardiac patients, whether he is able to climb, how many steps is there, steps, okay, that you see the guidelines. I am not very, because I did not get patients, okay, even cerebral sometimes you do get, but steps it is there. How many steps you can, one step or not able to give, okay. Similar to MRS, grading is there, okay. The grading is there in the book. For that specifically we have asked cardiometry is there. Speech also it is there, speech. Again you have to do the speech, then there is chart is there is a chart, okay, in the speech chart which I have sent, it is there, okay. Just a bit difficult because dysarthria is cranial, this one, there it is 25, 50, mild, moderate, severe, okay, dysarthria, but this speech, that is of course a little bit more difficult. The chart there in the 9, okay, in that one, okay, that one, the chart, speech discrimination score is there. English you can do that. You need help of audiologist.
Sir,
I always take the help of other people.
Age is also a factor, no? Age is usually the certificate is issued between the age of 15 and 50 years or something, no?
No sir, disability can be issued to any age, but less than 18 years, always tell, till 18 years we will give, after that one more assessment. Once the person completes 18 years, we will give one more assessment, because growing age, 18 sir, 18.
So there is one case from Kerala here. You are already started saying that he was impotent. How to assess it?
Impotency, I always take the help of urologist. They do plethysmography, ultrasound, all those tests, okay. But we have telltale signs. Already S2, S3, S4 is damaged, okay, by pelvic fracture was there, okay, urethral injury was there, everything is there. These are the evidence. And then of course urologists do the test, okay. Then I take the help of urologist.
Sir, what about the cognitive disability? Do you do it yourself or do you refer it to the?
I do myself.
You did.
IDEA scoring is there. IDEA scoring, I think I can show it. IDEA scoring, that simple one, okay. For 0 to 4 you have to get. 0 means nothing, 4 means profound, okay. Each component, 4 values are there. Then it's simple, okay. You just have to ask few questions, that's all.
We are not following a psychological.
Clinical psychology test is only corroborative for us. There, this is Kamath Bennett test is there, PJ battery is there, okay. So many tests are there, okay. The battery they use, okay. Niemann battery they use. So many tests are there. They don't give percentage. I mean, they tell that this log is this one. That is our corroborated to our certificate. They don't give disability. They will help us to say that there is a problem. We can always say in the court, doctor, what is the proof? I have the clinical psychology test.
Yeah, we usually refer it to the clinical psychologist for the Niemann's battery test. That's what I was. Sir, did you have this issue of over-assessment if you strictly follow the
Yes,
government guidelines?
Government guidelines is, if you strictly follow, it will give 80, 100 and up. Okay. I use my jurisdiction to reduce it, to come to a narrow down. Okay, because the guideline says too much. For every person is disabled. Okay.
Sometimes we'll have to use our own
You
discretion.
have to reduce it.
cut
You have to
down.
reduce it. You have to reduce it. And you have to also think that after 1 or 2 years, how the person will be. 6 months you have assessed, maybe 1 or 2 years, even more improvement can happen. That should not happen. Okay. Your patient can say 50% ability. After 2 years, he is bike ride. Hi, sir. Then that should not happen. So always give a lower side.
So thank you, sir, for such a lucid and jovial presentation. Hope
Thank
to
you.
listen to you, sir.
Congratulations. And one advice, I think it is better to be videographed, your examination. In order to prevent
They always ask for
litigation.
the notes, clinical notes you have done during the time of assessment. I say that I will give in the certificate only everything details. But of course, my findings I will write in the case sheet also. Same thing.
It is better to be radiographed.
Yeah, maybe in future they will ask.
Yes. Oh, you are referring the case by the court.
No.
But if it is, privacy is not protected, it's not for everybody to know what are the deficits of privacy. So unless you have that in place as a robust mechanism.
But if you have to answer a medico-legal question, then or someday somebody may sue you because of this error in this, calculating this disability certificate. If there is document with regard to this VDF, if VDF is there, it is very, very much helpful for you.
Yeah, we can always be sued for issuing false certificate.
Thank you.
Thank you.
Thank you very much, Dr. Ulla Shetty, sir. I would request the chairpersons to felicitate Dr. Ulla Shetty, sir, with a memento and a certificate as a token of gratitude and appreciation.
Which one?
I now call upon Dr. Shyam Kishore, sir, to felicitate the chairpersons as a token of gratitude. Thank you very much, sir. We will now break for tea. The next session will begin in 5 to 10 minutes, maximum by 11:50 p.m.
If there is any issue, please you can come and let me know. Yes, postgraduates. Staff presentations will run as per schedule. The next session will begin by 11:45. We'll have a quick 3 ನಿಮಿಷ ಇದೆ, 3 minutes ಇದೆ ಹಾಗೆ. What time? No, your flight what time is it? 3 o'clock. So you 3 we will do something. Okay. Who is your judge? I'll check the judge.
We will resume our session now. I request all delegates to kindly be seated. I take pleasure in inviting Dr. Nagesh KR, who is a professor in the Department of Forensic Medicine and Toxicology from Father Muller's Medical College, Bangalore, and Dr. Vishar Kolhapur, who is a professor in Department of Forensic Medicine and Toxicology from JNMC, Belgaum. I invite you, sirs, to chair the session. I take pleasure in inviting Dr. Ashwini Kumar, who is an associate professor in the Department of Forensic Medicine from KMC, Manipal. We welcome you, sir.
Okay, good morning everyone. So it's my privilege to introduce Dr. Ashwin Kumar. He is currently working as a professor in the Department of Forensic Medicine at Kasura Medical College, Manipal. Apart from MBS and MD, has done several other degrees like MBA in Healthcare Service, Postgraduate Diploma in Medical and Ethics, and Diploma in Cyber Law. And he has worked in several posts in his university, and he has published several articles in national and international journals, and also he has contributed in a chapter in some books. So I'm happy that actually he was my student earlier, and I'm a chairperson for his one of the this topic. So he's giving a talk on role of allied health and nursing professionals in dealing medico-legal cases. So over to you, Ashwin.
Yeah, good afternoon everyone. I am Dr. Ashwini Kumar. I am Associate Professor in Department of Forensic Medicine, KMC Manipal. As you have seen, Dr. Nagesh he is actually currently working in Father Muller's Medical College. But once upon a time he was in KMC Mangalore and I was his student. I was his UG student and I did my first autopsy with him. So today I am standing before him. It's a proud moment for me more than him. Thank you. And for my presentation per se, firstly I bring greetings from Manipal, and at the end I'll tell you what these greetings mean. So I'll be dealing with the topic role of allied health and nursing professionals in dealing with medico-legal cases. So as you all know, allied health professionals or nursing professionals, they basically are the supporting structures for us. And they are mainly based for patient care. But here my topic per se is actually extension of their work towards providing justice. So in what way they can actually support us, they can assist us in delivering justice. So before going further, I'll tell certain cases wherein they had an impact on the verdict. So one of the case was State of Maharashtra versus Ramlal, wherein Ramlal was convicted of culpable homicide for setting a victim's clothing alight. So means he actually put fire on the victim. That is what actually was the allegation. Now what happened was, in the defense, there was one physiotherapist who was called for, and that physiotherapist did a detailed assessment on mobility and the burn patterns. He also did gait analysis and he did something called scar assessment to understand the ignition patterns. So at the end of it, based on his report, the High Court found reasonable doubt about the history. So whatever the allegations were there, that was dropped, and the person Ramlal, he was acquitted. So if you see here, physiotherapist per se, he made a difference on the verdict. The second case is on State of Kerala versus Clara Joseph. So Clara Joseph was convicted for grievous hurt after a domestic assault, allegedly left the victim permanently disabled. Here, occupational therapist was called for, and he did the functional assessment. He did something called as ADL assessment. That is daily living assessment. Whatever activities are done in a daily living, ADL, activities of daily living assessment. So based on that, he gave a report that there is full recovery, functional recovery of this particular person. And based on this particular report, the Kerala High Court reduced charges from grievous hurt to simple hurt and converted the sentence to probation. The third case is of State of Tamil Nadu versus R. Prakash. This is an assault case in which there was actually it was a dark alley and the police witness testified against Mr. Prakash. So here the person who helped was speech language pathologist. He did something called as voice lineup experiment, which is nothing but a Doppler effect, and actually proved the prosecution wrong, because of which the person got acquitted. So if at all you see, all the people, they are actually paramedical personnels, and they had a say and they had an impact on the verdict of these particular cases. So allied health professionals, there are many, but I have actually put up only 17 major allied health professions here, which has an impact on forensics. So out of these, around 10 allied health professions per se, they usually take care of medical negligence suits, and they act as corroborative evidence. Means if there is any discrepancy in the case, at that time they will be called for to look in for the discrepancies. Other than that, there are 7 other allied health professionals, which I have actually classified into 3. One is diagnostic technologies, the other one is therapeutic interventions, and the last one is the specialized care. Specialized care is the care which is given to the patient care per se. So they all deal with medical negligence suits. Whereas when it comes to diagnostic technologies, we use them. Medical laboratory technology or radiation, the medical imaging technology, all those things we actually use them. Other than that, even therapeutic interventions like physiotherapy, occupation therapy, these people help us in assessment per se. Even for disability certificate, what was spoken by Dr. Ullas earlier, like we can also actually like ask the help of them to understand those. So whenever it comes to medical imaging technology, we usually like sought the help of these in cases like ballistics, wherein actually there is a gunshot. We'll know the trajectory, direction, where it is placed, where is the projectile, all those things actually we'll get to know based on the reports which are given by them. Other than that, commonly we see RTAs. These RTAs will have internal injuries. So whatever, like probably like outside it might not showcase anything, but inside there might be lot of injuries. Those things are being actually like given by them, and this can be actually like put up as a proof. Medical laboratory technicians. See, day in and day out we get cases of like poisoning and like certain times actually disputed paternity and a lot of things, identification issues and other things. So these cases we need the help of this medical laboratory technology. Any mishaps done by them, it will have a direct impact on us. Let's presume like we sent a sample and that lab technician per se, he actually like didn't preserve it properly or didn't actually like work it out properly. There is a contaminant or whatever it is. Ultimately what will happen is we'll get a wrong report and the justice will not be served. Speech language pathologist as well as occupation therapist. In this speech language pathology, they'll actually like see what is the level of like disability or effect by an injury. So ultimately it will actually work out when it comes to like disability certificates or compensation issues, all those things. Occupation therapist in forensic assessment. Basically these people see the functional ability of a person. Most of the time, let's presume it is a trauma related case. It can be anything, accidents, assault or whatever it is. These people play an important role. You've seen like the earlier case wherein actually verdict actually somersaulted. So this is because of one of the like very strong reports which was given by an expert. Now, what are the acts which govern this? So there is something called as Paramedical Council Act. This is actually a state-wise act, means actually every state will implement it. So in Karnataka it was implemented in 2012, in Kerala much earlier, it is 2007, and in Maharashtra 2017. So like there is actually a particular like acts which are being put up from different states based on what the requirement is. So ultimately, like if you see the things which are being actually depicted in each act will be different, but the concept is same. So now coming to this, like in Paramedical Council Act, they have also included nursing. But nursing, it is not actually stressed upon much because there is also a separate council. Nursing council is there. That particular thing will take care of other things. Now in continuation with this, in 2021, there was another act which was called as National Commission for Allied and Healthcare Professions Act. This act, what it has done is, it has actually like classified 56 allied health professions and acknowledged allied health professionals as healthcare providers. Other than that, it has defined boundaries and standards for professional services, and it has made everyone legally liable. So legal liability has come to these allied health professionals. If at all there is a mistake which is done by an allied health professional, he will be liable. Secondly, there will be vicarious liability to the healthcare provider, like probably the doctor with whom he is working. Also, there will be vicarious liability to the institute. So all the three things will be there. Now, when there is liability, there will always be accountability, responsibility from this particular people. So this particular act per se, it has also improvised the syllabus structure, and it has also actually posed like the disciplinary action which can actually go against allied health professionals. Now like if at all you see, like we have ethical guidelines which are being prescribed by NMC. They also have been prescribed in this, the ethical guidelines which are to be followed by them. Now if at all they get convicted in a court, they are also professionally liable. They can also be like called under the councils, and they can also be tried there, similar to that of NMC. Coming to nursing professionals, there are actually many subcategories or the like postgraduate courses in nursing. But these are the courses which help forensic people. Like if at all you see medical surgical nursing, it will help in documentation of injuries. It will also help in medical negligence suit. It will like community health nursing. It will help in maternal and child mortality. And if at all like you see like psychiatric mental health nursing, they also like help or assist in mental status examination or mini mental status examination, what we do today. So like every branch per se, it will have its own importance and impact. But when it comes to discrepancies, certain times they are being called. Till date, like there are not much of cases in India which are reported wherein actually nurses have gone against or whatever it is. But whenever it comes to medical negligence suit, their evidence or the records what they have maintained, it has been taken as an evidence. It will help in actually establishing or diminishing the status of medical negligence. Forensic nursing, this is the newer concept which has come into place now in India. So forensic nursing, it is actually like connecting the nursing care into the forensic science branch. So what is happening here is they want to improve the quality of collection of evidence and preservation and to maintain the chain of custody. Because nurse is the person who is the direct support. So ultimately, if at all they are made strong, it will be a good supporting structure for the doctor. And there is a concept called as SANE, that is sexual assault nurse examiner, which everybody might know here. It is actually like presently like practiced in UK, US and other places, but it has not yet come to India. There are some pilot studies which are done in India, but till date actually it is not actually properly done. Why? Because SANE, it is actually a qualification only given for certified individuals. That needs to be a specialized training, there needs to be specialized certification. Only after that, that particular person becomes SANE. And it has not been actually like put up in our curriculum, or there is no specialized course which is started. But in India, there are two places. One is NFSU, National Forensic Science University, and the other one is University of Jammu. They have started these two courses, MSc in Forensic Nursing and MSc in Nursing in Forensic Science. So either of the courses, they actually give them expertise in handling sexual assault, domestic violence, child abuse and neglect, substance abuse, traffic accidents, all those things. Whatever is the medico-legal like cases what we handle, in similar fashion they are being actually trained for to work as a supporting structure. So basically like this started in 2021, till that particular time forensic nursing course was not there. So since last 4 years this is being running, and this has extended the scope of forensic. Now like what has happened is nursing per se, like nurses never used to go to crime scene. But currently, after they finish this particular course, they can assist the forensic personnel in crime scene investigations. They can even actually be a part of autopsy team. They can help in sexual assault examination. They can help in recording dying declaration, all those things. So like it has extended the scope to forensic. Forensic nurses can provide courtroom testimony as expert witnesses. This is a myth. It is not there in India. It is there only outside. If you see, I have actually chosen the picture in similar fashion. Currently, like there are not much of cases wherein actually nurses are called to the court. Probably like in other states it might have, but like whatever I have actually like seen, till date only like the documents have worked out, and gross discrepancies in medical negligence suit. Like there was one case of postpartum hemorrhage, there actually the nurse was called for. Means to see whether there was time-stamped documentation. Means there is postpartum hemorrhage, how much time interval, like what intervention is done, within 10 minutes what is done, after half an hour what is done, after 1 hour what is done, like that. So whether that time stamping matches to that of the doctor or not, that is being actually assessed. Coming to functions of allied health professionals and nursing professionals. So basically, nurses and allied health professionals are often the first responders in MLC. If at all you see, the first thing what we do in any examination is history. And when it comes to these people, if they are trained well, they will know how to actually give the psychosocial support for a victim and extract all the relevant data. So the relevant history, the first person who responds, if he is good, he or she can actually extract it completely. and they can actually provide a platform for actually much better quality of examination. Documentation, as I told, it is a corroborative evidence. So whatever nurses are trained, if you see even in their BSc nursing or whatever courses they run, it will be like more of writing, documentation, the right way to write. So why? Because in the court, most of the times their writing is going to save the doctor. And it should always be time stamped, and they should always have followed standard protocols. So like I'll come to that at a later point, and signed and dated. Coming to the next part, it is evidence handling. If at all, like let's presume we are working in CFMU and there is a nurse. So they are supposed to like ensure that the evidence is properly collected. They are supposed to preserve it. They are supposed to label it and seal it at a later point. So they are supposed to maintain what is called as chain of custody. So this particular part is very, very important. Mainly, like why I am telling this is important is, it is called like evidence handling. The quality of evidence handling will improvise when they know the importance of it. Now we suggest that everyone should follow ISO 21043 guidelines. This is the guideline which is given for chain of custody currently. The old ones have been actually taken out, and the next thing what is coming is using barcoding system for chain of custody. So like it will come in a while. Currently like it is in planning mode and it will be applied in India soon. Photography. So any injury or any like issues, medico-legal issues, when it comes, we need documentation, not just actually in writing. Certain times, like what we say, a picture will speak 1,000 words, something like that. So like we need photographic evidence, and that photographic evidence might be detrimental certain times, and it will actually showcase each and everything. So this photography per se, one of the very important points is scaled photography. That is what is being suggested even in their curriculum. So currently forensic nursing curriculum prescribes all these things, like photography, how to actually take and how to like gauge. Gauge means actually like how to measure it based on the photography per se. Other than that, mapping injuries, they also teach on mapping, and even crime scene photography, all those things are being taught to them. Expert witness. See, this particular thing, they are being equipped now. It's been only 4 years, but like there are actually legal experts who are providing training to the forensic nursing per se, and they are actually like going to come as expert witness soon. Now, if at all in your hospital there is some complex case, let's presume it is a complex case which has actually like a lot of issues. So at that juncture, what I would suggest is, this is actually a US concept wherein they say that the hospital should have a MLC review committee. They should call for forensic personnel, they should call for the respective allied health personnel and the nursing, whoever is actually taking care of it, and the legal personnel who is actually dealing with it during the time of handling the case and when it comes to the court, both the times. So this review has to be done so that the patient care is good, and later on, once actually it goes to the court, the outcome will be favorable to that of the hospital. Regulations. There are actually many regulations which are being put up by Consumer Forum. So like Consumer Forum, everyone knows. So like currently, like this is going to get included in even the curriculum of paramedical courses. Till now actually like it was for us, and like even for nursing, the forensic nursing curriculum has it. So like for even the paramedical courses, they will also be involved because the legal liability is shifting to them. Indian Penal Code, there are actually few codes which have written down. It is actually, see, 33 BNSS is nothing but 39 of CRPC. It is mandatory reporting cases, like if at all like there is like murder or like POXO cases, what we actually discussed yesterday. POXO cases, it should be mandatorily reported. If at all it is not reported, what will happen? it is punishable. Now what will happen is like here only nearby there was one of the cases. So in that particular case, it was 17-year-old girl, and there was actually this, it was POXO, and the parents told that there will be a lot of stigma, and they like cried at the feet of doctor. Now this doctor, he was like very emotional, and he told, okay, inform, and he didn't document much, and he sent. Later on, there was another complication during which this doctor was not available. They went to another person, and that person directly intimated the police. And within a month or two, like the first doctor got an intimation that he is booked as accused. He is accused number 3 in that particular case. You might have heard about it. There is actually a lot of, so I think twice this has happened in the past 6 months. So like mandatory reporting cases, that particular cases have to be reported or else it is a punishable offense. Now like what can allied health professional or nursing person do? They can only tell the doctor that actually you have to intimate. See, they have to prepare a checklist so that actually doctor will not falter. 106(1) of BNS. This is nothing but 304A of IPC, which was earlier, Rash and Negligent Act. 125A and B of BNS. This is Rash and Negligent Act, which is causing hurt or grievous hurt. So basically 3 years and like 10 years punishment, all those things are actually being put up here. So that is the Indian Penal Code, under which actually most of the time these people come under. Clinical Establishment Act. I'll tell you one small concept which is actually like important when it comes to Clinical Establishment Act. So like there are actually like outpatient cases, inpatient cases, medico-legal cases, all those things are there. So like it has prescribed that you are supposed to maintain the outpatient records for a period of 3 years from the starting point, and 10 years for the cases which are inpatient. And if at all it is MLC, you are supposed to like keep it till the case is closed. Okay, it is like it is said indefinitely, something like that. So this is supposed to be the work of the nursing staff. Whoever is the nursing staff, they are usually in charge. In our hospital, they are in charge. Through them actually it will go to MRD, the Medical Records Department. Paramedical Council Acts, which I already spoke earlier, they also govern how actually things run. Now coming to what are the challenges and what might be the future prospect of these people. So like what will happen is, currently like we have one of the very problematic challenges in the rural areas. We don't have much of facilities, much of technology exposure, due to which the uniformity in handling cases in urban areas and rural areas are not there. None of the person wants to go to a rural area. So like if at all the government actually like works out on this account, there can be some uniformity which can be established. Secondly, there is no standardized curriculum. In like every paramedical course, if at all, there can be actually like curriculum which is put up by forensic, that would be great. Means actually like anyone over here can actually take up that particular task, can talk to the government, show one model in one of the states, that would actually like taken further on. See, like one working model will be a proof, and through that actually like every state can actually follow this particular model. So there is no uniformity as of now, but during this revision, when actually like the revision of these particular paramedical courses happen, I think forensic will become important. Legal clinical collaboration. See, most of the people, either paramedical or nursing or whoever it is, they wouldn't know how to give evidence in the court. They need exposure, they need legal expertise. They should know like why they are going, how they are going, what is going to be asked, what is the interpretation of those questions. So they need some legal awareness also. Coming to the future prospects, the digital health records. So this is a digital age, everything now electronic medical records and other things are going to come. So at this juncture, you cannot tell ignorance is bliss. you need to have knowledge, you need to equip yourself. So at this juncture, that is one of the challenges, because like there will be a lot of people who wouldn't be tech savvy, and there might be a lot of issues which might pop up with documentation. Typing and other thing might not be actually like easy, right? So there are actually like new technologies coming, along with that AI is also coming. So we have to equip them how to handle this. Like in US and UK, what they do is, it will be speech to text. Means they cannot type all through, right? So like it will be speech to text. They will actually speak up and the whole thing will become text. And there will be something like a correction factor. Auto correct will be there for the grammars and other things. And later on they can check it and they can approve. So something like that. So everyone needs to get aware about this. And even when it comes to diagnostic, currently AI is going to automate most of the things. AI is actually developing rampantly. So this is one of the a very major challenge for us, like how to train everyone so that things will be uniform. See, like there might be people who are good, there might be not good, like that. But at the end, for delivery of justice, we need uniformity. To conclude, I would like to say that allied health professionals or nursing professionals, they are an integral part of our team. If at all one person falters also, issue will be for us. We should help them in actually reformulating their syllabus, as well as we should develop standard operating procedures. See, if at all we have something like, okay, sexual assault victim examination, we should do like this. We give a protocol, we give a standard operating procedure. If at all we can give it to everyone, all the team players, that would be better. Always they come in as a corroborative evidence. They may or may not be called. They will be called whenever it is necessary, whenever there is a discrepancy. And legal and professional liability is being actually put up now for them through the Act. Through the new Act, they are also legally liable, they are also professionally liable. But what has made them? It has made them more responsible, and it has extended their duty from patient care to also justice. So it is justice with patient care now. So I always say in MLC, it is just like a chain. There will be multiple people forming the strong chain. And in that particular chain, even one person falters, the whole chain will break. So if at all, let's presume one sample is not preserved appropriately, or chain of custody is not maintained, or some documentation issue is there, that particular chain will break and ultimately justice will not be delivered. So great things in business are never done by one person, they are done by a team of people. This was told by Steve Jobs, and it applies well to this particular talk. So I thank the organizers for providing me this opportunity, and if at all any questions, I am happy to answer.
Okay, thank you. Thank you, Dr. Ashwin. You have beautifully explained the role of allied health professionals related to forensic evidence, preservation, and how the future that in India related to handling the medical legal cases. So if any question is there, open to comment.
No, it will come into vogue now. Currently, it is not fully practiced. See, what happens is whenever medical indemnity insurance is put up, it is currently not actually involving allied health professionals or nursing professionals. It is currently till the doctor. Now actually it will be extended. Once it extends, then only it will work out. Till now it is not there.
In Karnataka, there are so many in Karnataka, in Yenapai also, Jain University, we have that forensic science BSc courses. That only sufficient, they can be And the one question always then comes on our mind that what is the scope for them in India?
Okay, so like, see, BSc Forensic Science per se, they will not be able to like handle everything. They will be like handling evidence, the trace evidence or actually like crime scene or whatever it is. They will be trained in a particular aspect. Now like here actually like when it comes to allied health professionals, like let me like give you one example, like let's take like occupation therapy. They are actually like day in and day out, they are actually handling how this particular person is functionally capable to perform. So that will not be the expertise of a BSc Forensic Science. So at that level it is different. Their functional expertise is different than that of BSc Forensic Science. Now coming to the scope of BSc Forensic Science per se, they can actually do MSc Forensic Science, and after that they can do PhD and they can actually join other courses. Means like other like RFSL they can join. They can even actually do like 6 months training or 1 month training in cyber security. They can go in for that. Ballistic training they can take. They can actually become ballistic expert like that. So they can actually like complete their post graduation and they can actually get training in particular aspects and join RFSL.
University Archaeologists has introduced this forensic nursing one subject
Okay.
last year.
Yeah.
But it's not it's not there for the exam, but not for the exam.
Okay.
Just they have introduced last year the forensic sciences, sorry, forensic nursing subject in the BSc nursing.
That's a nice one, sir. That I didn't know. Yes. Yeah.
It is a
Forensic-
national.
But they have Indian assessment exams as well. But there is no university exam. It is being included in the curriculum.
Correct.
And the Kerala government recently issued an order stating that one district nursing officer included in the panel of members to assess the medical negligence.
Oh, okay.
Anybody, any this liability is against the paramedical persons, this can be also reviewed in the form.
Superb. That's nice. Nice information.
Officer is included.
Oh.
I think these are the nice developments.
Yeah, yeah.
Maybe like-
2025 for
Yeah, this
Yeah.
is in a continuation reflecting on Dr. Kishore's question
Yeah.
of allied health vis-a-vis forensic science. I think some of the courses have an inbuilt care component, a patient care component, which can be used in the forensic services, which will have a better delivery because they have in the philosophy of care,
Correct.
vis-a-vis the research component which is delivered, like forensic science, because then they don't have a empathy as one of the component which builds on the patient care.
Correct, correct.
So when for a long time, even for forensic, we always looked from the autopsy lens.
Correct.
We never looked at the clinical forensic, and so the empathy which was supposed to accompany us to a person, to a dead, to anything, was a bit lacking. So I think it's good that with this allied health, if they have both the components of this as well as medico-legal, then the examination of any person, whether medico-legal or healthcare, may have a better approach.
Correct, correct. Thank you, ma'am. Thank you on that note. And one more thing I would like to add on, because sir told like on those, and Harish sir also told something. So like there is like one person called Dr. Renjulal. He is currently in Manipal. He is in nursing. So like he did a PhD on this one, SANE, Sexual Assault Nursing Examiner, and he did one pilot project. And that pilot project was successful, and like he has like approached the government to actually like establish the course. Currently like it is in the like talks.
3-4 classes, depending upon, I think more than that. 3-4 classes, depending upon, I think more than that. Yeah, 40 hours. 40 hours we have.
I think
It's
university
really nice.
can bring in that into assessment.
Yes,
Okay,
yes.
that National Commission has not recommended assessment, but you can bring in little like no weightage to that assessment also.
No, if at all there are takers, it can be started. The course per se can be started, but only thing is you need somebody to take it.
No.
So like the nursing council per se, it has already like approved it, and 2 of the universities have already started it. If at all there are takers, you can also start and see, probably 1 or 2 years.
Ashwin, it is integrated, I mean integral part of that.
This is integral part. sir. I'm telling you is, you can start MSc forensic science only, like, I mean to say, nursing, nursing.
No, that may come up. I think that our, what is that, sir is working on that in a national level.
National Forensic Science University.
Yeah.
And University of Jammu, both have already started, and they have the curriculum running since past 4 years.
Yes, yes.
And there are takers there.
Yeah.
Like if at all like they start, there will be takers.
Okay. Any other questions? Otherwise we'll wind up.
I just want to add on.
Yeah.
Even dental curriculum, now the DCS introduced forensic as a...
Yeah, forensic odontology. Yeah, we do take classes for them.
But they're it's on temporary basis, ad hoc basis. I think the forensic, you can take the help of the forensic department. In future, they are expected to hire their own forensic staff or forensic odontology staff.
Oh, okay, okay, nice.
Okay.
And yeah, just one.
Okay, we'll wind up here. Dr. Ashwin, thank you very much for your lucid presentation.
Yes, sir. Can I have one moment, sir, with the crowd?
Yeah.
It's coming. Yeah, this one. You just play the last. Sure. This one last slide. Yeah, after this. Yes.
Yeah. So like I was telling you, warm greet Manipal, right? So like we are hosting one international conference that's in October 4th and 5th. There are like renowned speakers all across the continents. Like we are having speakers from US, UK, Australia, 2 speakers are there. Like that, a lot of people actually from outside are actually coming. It will be a huge academic feast. Kindly join us. Be happy to host. Thank you.
Okay, thank you.
Thank you very much, sir, for that wonderful guest speech session. I now request the chairpersons to felicitate Dr. Ashwini Kumar with a memento and a certificate as a token of gratitude and appreciation. Thank you, sir. May I now request Dr. Veena Vaswani ma'am to felicitate the chairpersons with a memento and a certificate as a token of gratitude. Thank you very much, ma'am. next session will be chaired by Dr. Balachandra Abad, who is a professor in the Department of General Medicine, Yanapaya Medical College, and Dr. Ullas Shetty, who is a professor and HOD of the Department of Forensic Medicine and Toxicology from AJ Institute of Medical Sciences. And the guest speaker for this session will be Dr. Ravichandra Karkal, who is a professor and HOD in the Department of Psychiatry in Yanapaya Medical College. We welcome you, sir.
Sir, it is my privilege and pleasure to introduce Dr. Ravichandra Karkal, who is Professor and HOD in the Department of Psychiatry, Yanapaya Medical College. He has more than 30 publications in national and international journals. He is also the past president of Mangalore Psychiatric Society. He is here to enlighten us on the session Medico-legal issues in psychiatry. Over to you, sir.
Good afternoon, everyone. So, thank you, Dr. Balachandra, for the introduction. So, I'll start with a disclaimer. I am not a forensic psychiatrist by any means. I am a clinical psychiatrist, usually engaging with adult psychiatric issues and once in a while child and adolescent issues. And I may sound a little insensitive when I use certain terms here, such as lunatics, insanity, words like that, which unfortunately, if you look at the historical perspectives and the terminology in the law books, they still stick with such insensitive terminology. So I don't want to hurt anybody's sentiments, but I may use such terms because of the necessity. And I want to acknowledge a forensic psychiatrist, actually, a colleague in NIMHANS, Dr. Suresh Badamat, who is, I can say, one of the few forensic psychiatrists in India, and he's an authority on a lot of the issues that I'm going to discuss. And I think material which I've got from him, I've heard him, speaking in conferences. So most of the material, would be on that. I have very limited experience of handling civil litigations. I'm called as expert witness for some of the civil litigations. So that is the practical experience, to be very honest with the audience. Now, psychiatry stands at a very unique crossroads of medicine, law and human rights. Very few other medical specialties demand such a delicate balance between care and control, autonomy and protection, liberty and risk. So every day I ask myself whether I am violating the constitutional rights of my patient. So when I admit a patient against his consent, when they don't have capacity, I am basically violating their constitutional right to freedom, right to personal liberty. So you can understand the moral dilemma that arises, in a clinical psychiatrist like me. So it's a very unique intersection that psychiatric practice stays at. There are some very peculiar challenges in the field of clinical psychiatry. So one is mental illness and disability is invisible, and most of our assessments will appear very abstract to a lot of other medical professionals, because it includes assessment of thoughts, emotions, behaviors, memory, perception, So for a lot of other medical professionals, this may seem very abstract and not very sciencey, So that is another challenge, whenever we have to produce evidence, it's only based on that. So there are no biomarkers in psychiatry, there is no imaging or a lab test with which I can prove somebody has schizophrenia or not. And evidence is based mostly on history, mental status examination, cognitive function testing, and observation of behavior of a person in the ward. And a lot of our clients lack insight into their illness, so they don't believe that they are ill. So it becomes a challenge to actually treat them. You want to help them, but the person is refusing help because of lack of insight. And add to that the stigma and discrimination that is there with mental illnesses. So there is so much of risk that our patients are because of the vulnerability. Mental illness itself is such a vulnerability, and because they are concerned about getting labeled as mentally ill, coming for treatment or accepting treatment, or even when we genuinely want to take care of these people, there may be lot of conflicts there that we have to face. And most of the psychiatric issues are chronic. Some are chronic, some are remitting. For example, a patient with bipolar disorder, which has a very episodic course, may do a certain set of acts when they were in the middle of an episode, and then there may be a period where there are no symptoms at all, they are in full remission. So we may have a remitting illness like that, and there may be relapse also. So you have done an assessment, say for example you have assessed capacity, say to stand trial in a court at one point when the patient is in remission, and then there may be a relapse which makes the person incapable of basically standing a trial. So we deal with illnesses which have such course and characteristics. It makes it a little challenging to handle such cases. And as I told, there are a lot of ethical dilemmas that we face every day. For example, if we think of the ethical principles of autonomy and beneficence, every day I have to admit patients against their wish, so I will actually violate the patient's autonomy. And beneficence, so many times it has happened. I can quote one example. I was called by the court as an expert witness. So wife had applied for divorce, and I know that my patient has a chronic illness of schizophrenia. He was not working from about 15-20 years, not at all employed for the last 15-20 years. So somewhere I know that wife is right in giving the divorce application. But I am thinking from the doctor's perspective, because we psychiatrists are basically trained to think as an advocate for our patient. So it becomes very difficult to stand in the court and give evidence. So I am telling, if I say that yes, he has this functional disability, he has these problems, I am basically, dropping the promise of care that I had given to the patient. So such ethical dilemmas keep arising in our practice. Also a dual role that we may have to play. For example, I am his clinician, the patient that I was talking about, I am his clinician, a treating clinician, but at the same time in the court of law I have to think from the legal perspective and give my answers. So I can't take the side of the patient. So such dual roles you will be put into, especially when you are called in the court. And add to this, there is very poor training and research in forensic psychiatry in India. If I think of my MD training program, it was at a central institute, and if you ask me what is the exposure to forensic psychiatry, it was almost nil. So it can be theory classes, but if I have direct experience of dealing with, say, people who were on trial for criminal responsibility or other such issues, it's very limited. And only in NIMHANS recently they have introduced postdoctoral fellowship in forensic psychiatry. That's the only specialized course that I can think of that is existing in India. So the MD psychiatry postgraduates, they have very limited training, and people who do work in this area, they keep telling that it's monetarily not attractive at all. So the cases that I was telling, I went to the court and gave expert witness. The remuneration that I get going to Bantwal, spending half of my day, is so meager that most people may not get attracted to the field. And we all know how sometimes it can be humiliating and insulting in the court of law, and most people don't want to get into this business. So and also lack of reliable tools which are adapted to the Indian laws and context. I will tell some tools later on. They are Western tools which I think they are not adapted to the Indian laws and context. So it becomes difficult when you are asked to do some assessment. Say for example, in case in future I get a case, you know, somebody who is on a murder trial, and somebody asks me to do an assessment, I will not be able to find anything like a you know, exact tool which I can use to do the assessment. So it all depends on my personal experience, or I will have to rely on other colleagues who have worked in this area. Now you know, in my lecture today I want to focus on the evolution of mental health laws in India, because that is you know, of paramount importance for me as a psychiatrist, and I deal with this day in and day out. So some important you know, dates, years, you know, 1858, 1987, 2007 and 2017 for the postgraduates here. These are some years which I think is important to remember when you think of evolution of mental health laws. So initially, you know, most of the acts like the Indian Lunatic Asylum Act or the Indian Lunacy Act of 1858 and 1912, they mostly focused on confinement and custodial care of patients with mental illness. And then in 1987, Mental Health Act was introduced. It focused on institutional care with some regulations and you know, licensing. There was focus on regulations and licensing, but you know, it only stuck to that. But what happened in 2007 is that India ratified the United Nations Convention on the Rights of Persons with Disabilities, UN CRPD, right, in 2007. So India became a signatory, and that compelled us to bring a law which is in alignment with the convention, UN convention. So in 2017 this bill was put forth, and the philosophy of Mental Health Care Act, which was introduced in 2017 and which came into force in 2018, is basically it focused on the rights of people with mental illness for the first time. Till this point of time it was mostly confinement, you know, people were worried about you know, public safety rather than the rights of the person who is actually suffering with these mental illnesses. So the philosophy is a paradigm shift, you know, in the mental health scene. So the Mental Health Care Act, which came into force on 29th May 2018, it has 16 chapters and 126 clauses, and the preamble reads, an act to provide for mental health care and services for persons with mental illness. This was there already, but it also talks about to protect, promote and fulfill the rights of such persons during delivery of mental health care and services, and for matters connected therewith or incidental thereto. So basically, during the treatment or, you know, management of such disorders, are we paying attention to the rights of these people? That, you know, the preamble tells a lot about a law. So that focus came with Mental Health Care Act 2017. So if we have to talk a little about Mental Health Care Act, the most essential thing for us which we apply day in and day out in taking care of our patients is something called as capacity assessment. So capacity assessment, you know, what is capacity? Basically it is an ability to understand benefits and risks of a treatment that is being offered to the patient, right? And the patient also should be able to understand, are there any alternatives to whatever treatment is being proposed, and taking no treatment is also an alternative. For example, a patient comes with depression, he is brought by his wife, patient may refuse treatment. He may have capacity, but he may say that I don't want any treatment, I don't want antidepressant treatment. So he has every right to say so. So in capacity assessment we focus on whether they have that ability to understand that and whether they are able to communicate this choice to us. And when I say ability to understand, they should also be able to, you know, analyze and reason the consequences of making a choice. So if they make a choice that I don't want antidepressant therapy, they should be able to appreciate what will be the consequences of making that choice. So if that person is showing that reasoning and is able to understand the consequences of his choice, he still, you know, it is valid that he may say that I don't want any antidepressant therapy. So another thing is, you know, by law everyone has capacity unless proved otherwise. Every person has capacity. And if if in your capacity assessment you find out that the person has capacity to make a decision, then you will have to take informed consent. You cannot treat anybody without informed consent. So if you are able to prove that the person has no capacity at that point of time when you did the assessment, then maybe you need not take the informed consent. Another important thing is, mere diagnosis of mental illness does not rule out capacity. As I already told, we come across many circumstances. Say for example, somebody who is dependent on alcohol, right? He's developed chronic liver disease, he's having hepatic encephalopathy, he comes out of hepatic encephalopathy, the medical fraternity is sent to us saying that you do something about the alcohol addiction. The patient may completely refuse taking treatment, right? So just because there is a diagnosis of substance use disorder or alcohol dependence syndrome doesn't mean he lacks capacity. I can't take decisions. I cannot take a paternalistic approach and say that I will tell you what treatment you should take. That, according to the act, that is not correct. And wrong decision doesn't mean incapacity. So this person may say that I don't want doctor any treatment for alcohol dependence syndrome, just because in my perspective he is taking a wrong decision doesn't say that he is not having capacity to make a proper valid decision. Then capacity is task specific. So for example, if I am admitting the patient, basically what I am assessing in capacity is whether he can understand what is this treatment, whether there are alternatives to this treatment, if he chooses a particular treatment, what are the consequences of that. If he is able to do that for particular task, that capacity is there or not there, only that. So capacity is also very, we say that capacity is a very clinical concept. It is very different from competence, legal competence, because all the forensic medicine colleagues here may be very well aware of competence. So there is difference between capacity and competence. Capacity is mostly a clinical concept and it's a spectrum concept. So for some specific task the person may have capacity, but for other task he may not have capacity. So it depends on the specific task. And capacity can fluctuate, as I already told. So a person, say for example with alcohol dependence syndrome, he is in delirium, he does not have capacity to make a healthcare decision. He comes out of delirium, I have admitted him, without his consent because he was in delirium. He comes out of the delirium and says that I know what are the consequences of my problems, you discharge me, he has to be discharged. I can't say that I have admitted you, take the full 21-day de-addiction treatment, no business of that. So capacity can fluctuate, you have to keep assessing. Once the patient has capacity, the particular sections that will apply from Mental Health Care Act will be different. Then another mistake that we do is we think of a diagnosis and immediately come to some conclusion that they will definitely not have capacity. For example, a person with say early Alzheimer's dementia, there is no, you cannot categorically say that they have lost capacity just because they have a diagnosis of Alzheimer's dementia. So a person with Alzheimer's dementia, early Alzheimer's dementia, may be forgetting whether he has had lunch today, or he may forget where he has kept his keys, but he may be very well aware what are his assets, who is the rightful people who has to get those assets and can actually distribute his property, right? So just because somebody has a particular diagnosis or a mental illness, you cannot immediately come to a conclusion that they don't have capacity to make certain decisions. So capacity assessment in Mental Health Care Act, as the name itself suggests, it's all about treatment of mental illnesses, Mental Health Care Act, right? So the capacity assessment here in Mental Health Care Act is mostly focused on the treatment decisions that we have to do every day as psychiatrists, right? So I'll just show you some forms, hope it is visible. So with the socio-demographic details, the date of assessment, place of assessment has to be done, has to be written. This documentation is very important. All of our residents and we psychiatrists act in the OPD. If we are admitting a patient, we have to fill this document and we have to send it to the Mental Health Review Board, District Mental Health Review Board. It's become a mandatory, documentation process. So we have to also specify what is the purpose of the assessment. If it is under section 102, 103, 102 is where, a person say is brought in front of the magistrate and the magistrate has sent for treatment, or say 103 is a person in jail, right? A person, imprisoned person who has come for treatment. So only those two sections you can skip this assessment. You can do it later also, you can admit. But for everybody else, this assessment needs to be done. We also have to check whether there is advance directive, nominated representative, these I will talk about in the later slides, and what is the provisional diagnosis. Then we have to see, the first step is, this is step 0, they say, is there an obvious lack of capacity? That means, is he or she in a condition that one cannot have any kind of meaningful conversation with him or her? For example, the person is violent, grossly violent, excited, catatonic, that is, they are not talking, mute, they are having bizarre postures, they are delirious, they don't have, their cognitive function is impaired, under alcohol or substance use, intoxication, severe withdrawal. If such things are there, it means there is obvious lack of capacity. So you can skip the middle steps, right? And you can directly go to step 4. This is the 0 step. Next, there is, you have to see whether the person has understanding of the treatment options. So you have to ask these few questions. Is the person oriented to time, place, person? Whether there is orientation. Then, has he or she been provided relevant information about mental health care and treatment pertaining to the illness in question? Whether I have given the information to them. And are they able to follow some simple commands, like say for example ask them to show their tongue, close their eyes, right? Basic assessment that you should do, and do they acknowledge that they have mental illness, right? So few things can happen here. The person may be disoriented. If they are disoriented, they have an obvious lack of capacity, there is a possibility. Then after giving all the information necessary, they may just say that they don't have a mental illness, they lack insight. So if they lack insight, then the psychiatrist will have to go for involuntary admission, right, rather than a voluntary admission. Then next steps that you have to do is whether the person is able to appreciate the foreseeable consequences of their choice, whatever treatment choice they make, right? So does the individual agree to receive treatment first of all? Then does he explain why he or she has agreed for treatment? And then if they don't agree for treatment, what is the reasoning for that? For example, a patient may tell me he is say for example having severe depression. So he may tell me that, doctor, I am a sinner, right, and I have been cursed from, I have been cursed to go to hell. So why do I need treatment? Then, that kind of a reasoning tells you that there is some disorder of thought. There is a delusion that is existing. Then you can say there is lack of capacity, correct? So if they disagree with your treatment choices, ensure that they give a logical reason for that. For example, a person with alcohol dependence syndrome, you have a mental illness because there is substance dependence, but he will give you a logical reason that, doctor, my body, if I have liver failure, it is my business. You don't have anything here. Then, that the person does have capacity. You can't really force him to stay in the ward or receive any kind of treatment against his wishes. So these are some of the things that, you have to assess. And then whether he is able to communicate that choice to you by means of, say, speech, writing, gesture, anyway, if he is able to say yes or no to you, whether he agrees with the treatment choices that you have given, then it means that he is able to understand the treatment options, he is able to see the foreseeable consequences of a choice that he makes, and he is able to communicate that choice to you. If these three are yes, he has capacity, and then you will have to listen to whatever choices that he is making, right? If there is not, then based on all the assessment that I told so far, you have to decide whether he has capacity for treatment decisions, including admission if it is necessary, or he needs 100% support from his or her nominated representative. A nominated representative can be a caregiver, right? They may not be say, they may not have given a written document to say that my wife is the nominated representative, but we assume that because Mental Health Care Act implementation is still in the early phase in our country, right? So if the wife is able to support, then they can be considered as nominated representative. And another thing is, I will tell later, maybe I'll come to this later. So this is the capacity assessment that we need to do every day for the treatment decisions that we are making. Next other important aspect of Mental Health Care Act is Advance Directive. So Advance Directive is a patient can give in writing that maybe in the foreseeable future I will lack capacity. So when you are going to treat me at such time where I lack capacity, you have to do these things. I mean, the treatment has to be according to my wishes. And say for example, somebody may say that I don't want electroconvulsive therapy if I become sick, say in the foreseeable future. So if such an advance directive is there, then you will have to respect that, right? Unless there are some exclusions, unless you know that you don't, if you don't give electroconvulsive therapy and he is at imminent risk of danger with say suicide or something like that, you can do some emergency treatments like that. But if there is an advance directive which he has written and he has registered with the Mental Health Review Board, that has to be respected. Another thing is, they can also appoint a nominated representative. It is the patient's or the nominated representative's responsibility to give the advance directive to the treating doctor. It is not the doctor's responsibility to find out whether there is an advance directive. And also there is immunity to the psychiatrist. If say for example the advance directive says that you should not give me antidepressants in say future when I become sick, and because of that action, because I respect the advance directive and I don't give him antidepressants, and he ends up in a consequence which is not looking good, say for example he attempts suicide, then the psychiatrist is immune from that, because the patient himself has chosen those, he has made those choices. So there is immunity to the psychiatrist. And what we have to remember is, if the patient has capacity, there is no need to look at the advance directive. Only when he loses capacity, he can, or the nominated representative can invoke the advance directive. Then about nominated representative, imagine no relative is coming forward for becoming the nominated representative or take care of the patient. Then other caregivers can be appointed, an NGO caregiver can be appointed, or the MHRB, the Mental Health Review Board, can appoint a person for taking care. And if nobody agrees or nobody is there, then the director of Department of Social Welfare, he is responsible for patient. So that's although ground reality is not so nice, but at least the act says that there is the state responsibility for taking care of these patients. At least it is put out in the law. And also the nominated representative can give consent for research, because some of our patients may not have capacity to give informed consent for your research purposes also. So the nominated representative can give you consent if he is in such a state where he cannot give consent for the research program. Then the heart of MHCA 2017 is rights of persons with mental illness. So I will not list out everything here, but it has to be requested by a nominated representative. Parents maybe, right? And patient will be parents maybe, right? And patient will be admitted only a minor's admission is seen, a minor's admission is seen as very critical, and two psychiatrists have to sign the document, and two psychiatrists have to sign the document for admission. They have to assess capacity and do it, or say for example a medical officer and a psychiatrist, or a mental health professional and psychiatrist. Two people at least have to sign the document if you are admitting a minor, and if you have to sign the document if you are admitting a minor, and if you are admitting a minor, within 72 hours you have to inform the Mental Health Review Board. So within 72 hours you have to inform the Mental Health Review Board. So you have to attach the capacity assessment form. There is an intimation form also. All those forms need to be sent to MHRB. We are sending an email to the MHRB ID, email ID so far. That is the mechanism in place, and it's very unfortunate, I have to tell you this, the Gmail inbox is full. Because there are emails pouring in every day, the Gmail inbox of MHRB is always full, so they bounce back the emails that we send. So you can understand the mechanism in place is not that great so far. So this is about independent admission. Then there is something called as supported admission. They are not using the word involuntary admission, something called supported admission. So supported admission can only be up to 30 days under section 89. A request is given by the nominated representative, a relative or a family member or a caregiver. Patient will be admitted if a medical officer or a mental health professional examines his capacity, and if he is lacking capacity, only then supported admission. Then if you are planning to extend the admission, say for example after 30 days, right? So you can understand we are detaining a patient for treatment. It's a very serious human right violation of restricting movement, right? So if it is more than 30 days, up to 90 days, 2 psychiatrists will have to independently examine and sign the capacity form and intimate the MHRB. So if it's a male person, within 7 days you have to submit the intimation to MHRB. If it is a woman or a child, within 72 hours you have to submit. So these are some of the things about the admission process under Mental Health Care Act. Now whether emergency treatment can be done, definitely up to 72 hours you can take some steps for emergency care, but there should be imminent danger to self or others. For example, see, treatment of persons with mental illness can only be done in a mental health establishment, a registered mental health establishment these days. But if he goes to a PHC and there is imminent danger to self or others, or if he goes to a private hospital without any registration, he can be given some emergency treatment and shifted to a registered mental health establishment. I cannot go to a place for treatment of persons with mental illness which is not registered under the state mental health authority. That is the law now, and that is a criticism of Mental Health Care Act, because so many people will actually lose access to care in a remote place where you cannot expect small hospitals to be registered under state mental health authority. So then there are some prohibitions and restrictions under the law. Psychosurgery is prohibited, right? For example, we don't do a lot of psychosurgeries, it is only in say treatment resistant OCD, but you have to apply for MHRB and take approval for psychosurgery. Gamma knife surgeries you may know about for OCD. Then unmodified ECT, you cannot give electroconvulsive therapy without anesthesia, completely prohibited. Then sterilization as a treatment for mental health care, no. Then chaining or solitary confinement is banned, and ECT in minors is also prohibited, but there is an exclusion if you are writing to MHRB that it is the only way with which the minor will respond to treatment, then maybe with the MHRB approval you can give ECT to a minor, otherwise it is prohibited. Then restraint, we use chemical restraint, we give sedatives, or we use physical restraints. This has to be done only to prevent imminent danger to self or others, and there is something called as the restraint monitoring form. Every hour we have to note down, we have to keep assessing capacity, we have to keep assessing whether there is imminent danger to self or others. Say after 6 hours you can't keep him restrained if there is no problems, right? And these restraint forms have to be sent to MHRB. Every time we restrain a person, we have to send. So practical, how practically we can do these things is again, very questionable. And it has to be authorized by a psychiatrist. So the restraint. Another good thing that happened with MHCA is removal of IPC section 309. So decriminalization of suicide attempts. So according to section 115 of MHCA, we believe that anybody who attempts suicide is under a lot of stress and he should not be tried for attempting. See, another aspect of Mental Health Care Act is they have defined the implementing authorities. Who is going to implement the mental health care laws? So at the district level there is Mental Health Review Board, at state level there is State Mental Health Authority and Central Mental Health Authority at the central level. And the screenshot that I have put is from the eManas portal. eManas is the Karnataka's State Mental Health Authority portal. The patient portal is still not active, where a person can apply for advance directive or where he can choose a nominated representative. It is still not active in the website, but the mental health care directory is there to see which are the establishments which are registered under mental health authority, and you can also use something called as a clinical module where you can enter some patient data and keep it saved, right? If you don't have something in a clinic, you can use that. Now another important aspect is criminal responsibility. So BNS section 22, which was earlier IPC section 84, I'm sure forensic medicine, everybody knows about the McNaughton's rule, and the important thing is the unsoundness of mind, the lack of reasoning. That is the essential thing. We have to differentiate between medical insanity and legal insanity. Just because somebody is diagnosed with schizophrenia doesn't mean they have legal insanity, right? And mere presence of mental illness is not enough. Burden of proof is on the defense, on the accused. He has to prove that he was suffering from such unsoundness of mind when doing the act that he is not criminally responsible. So one case, TN Lakshmaya versus State of Karnataka 2001, where a person applied for insanity defense, but what was seen was he elaborately planned the act. He took the family to a waterfall from a delusion that I am a sinner and my children are also sinners and I want to save them from all the suffering on earth. So if we are able to establish that such a delusion is there, then maybe the court may think of legal insanity, right? So every case of medical insanity does not equal to legal insanity. And also we have to collect all the collateral information and reconstruct the chronology of mental state before, during and after the offense to basically determine what was the state of mind while committing the act. And the forensic psychiatric report that one has to produce, it should have identifying information, reason for referral, sources of information, clinical findings, psychiatric diagnosis, and last but not the least, the opinion on criminal responsibility, which the key questions that I was asking has to be kept in mind when answering that. Now testamentary capacity, again, mental status examination is important, cognitive function assessment is important. For example, a mini mental state examination. If the score is more than 24, very less chances of lack of capacity. It's normal. If the score is less than 16, research has shown that there is a good chance that a person may lack capacity. But just a MMSE score doesn't tell you, as I already told, doesn't tell you that the person has lost capacity. What has to be looked into is whether he understands the nature of the will, effect of making a will, whether he is able to name all his assets, whether he knows the approximate value of each asset, will, whether he wants to execute the will in whole or part, whether he has to, whether he is distributing only part of his property, whether he understands the natural beneficiaries, right, which are there, or what is the reasoning that he is giving to include someone or exclude someone. For example, some patient may tell you, I am not giving property to this son because he is a demon. He is on this earth to, just ensure that I suffer. If there is, strong wrong belief, a delusion, then the person actually cannot execute his will. He has, the testamentary capacity is not there because his reasoning for excluding is not appropriate. And also you have to see whether there is any coercion from family members, whether they have wrongfully taken some left thumb impression or got a signature when he was lacking capacity, he was in, say, confusion or something like that. Also you have to establish whether there is a mental illness which can affect the whole process. Now marriage and divorce is another thing in persons with mental illness. So one is at the time of entering into the contract of marriage, both the parties, husband and wife, should be able to give a valid consent. So if due to unsoundness of mind, if the person is not able to give a valid consent, if we are able to establish that, the marriage is null and void, right? And also another case is, another thing that we see day in and day out is concealment of mental illness during marriage. And usually they put the case, the husband or the wife puts the case that there is marital fraud because it was not revealed to me that the person is mentally ill. And again, mere diagnosis of mental illness is not enough. we have to assess whether the spouse who has, put this case, whether they can be reasonably expected to live with this person with mental illness. If they are reasonably expected to live, then still the person cannot take a divorce. And then sexual dysfunction, for example, we know that if there is sexual dysfunction which is leading to non-consummation, it also stands as a factor for the marriage to be void, correct? And cruelty, mental cruelty or physical cruelty. Yeah. The fourth point, sir, reasonably expected to live. Okay, sir, basically the court will ask us, the person has mental illness. Just because the person is diagnosed with schizophrenia doesn't mean that the spouse, the husband or the wife, has every right to take the divorce. What it will ask is, what is the severity of illness? How is it impacting the marital life? Whether there are other problems, whether there is sexual dysfunction, whether there is cruelty, whether he is able to discharge his responsibilities, whether he is employed, whether he is able to provide. If all those things are not there in place, then the spouse has every right to take the divorce. That's the gist of it, sir. Then physical and mental cruelty can also be grounds for applying for divorce. Now, some guidelines for forensic psychiatrists or if a clinical psychiatrist is called as an expert witness. Don't jump to a diagnosis. If you are doing any assessment, don't start writing the diagnosis from the first day. Take your time to come to a diagnosis. Then admit for observation whenever possible. Collect all collateral information, first information report, social background report, forensic reports, court papers, photographs, urine toxicology reports, news reports, whatever is possible. Interview family, friends, colleagues, talk with the advocate, investigating officer, witnesses, visit site of crime if it is possible. Ensure that you are documenting properly and ensure that if you have a team of people, whatever you are writing is in sync with whatever the other people are writing. There are residents handling cases. They should not be writing something which will refute what I am assessing and what I want to imply. Then don't fall for common traps. When you are called in a court, the lawyers are so shrewd. They will ask questions like, I have been asked a question whether there is cure for this illness. So talking about a cure in mental illness is not at all possible. So I will have to say, look at the judge and say that, sir, I am not in a place to answer this question. So you will be put in a spot to answer such questions. So you should not be falling for such common traps. Another trap is, I have heard from my colleagues that, say for example, you do a forensic assessment of a person who has come for insanity defense, and the lawyer may ask you whether another professional in your place would come to the same diagnosis and same impressions. You will have to confidently say yes. If you say no, then you understand the problem, right? Lawyers are very shrewd and they will ask these questions to put you in a spot. And another thing is, if the opposing lawyer is not agreeing your diagnosis and assessment, you can always say Mental Health Care Act 2017 section 105, you constitute a board. If you are not agreeing with whatever assessment I have done, the court can always constitute a board and take a final impression on what is the status of the patient. So to conclude, psychiatry is at a very complex intersection of law, ethics, socio-cultural realities of a diverse country like India, and also clinical judgment of a clinical psychiatrist like me. So all these factors have to be kept in mind. So the good thing is that MHCA 2017 is promising to champion the rights of persons with mental illness. Forensic psychiatry training is pathetic in India. It needs to be enhanced, right? And psychiatrists sometimes may be called as expert witness. I cannot say that I will be completely unaware of the law and I don't want to, participate, right? So may be called as expert witness in several criminal and civil litigations. And psychiatrist has to forget for a moment that I am the advocate for the patient. I have to think of upholding the law and upholding public safety, right? Because as I told, as a forensic psychiatrist, you have the dual role that you have to take. So with that, I end the lecture. Thank you.
Thank you, Dr. Ravichandra.
is my hostel mate from Mysore Medical College. So I have seen lot of patients who have assaulted their relatives, mothers, grandmothers, stabbed. Even in Enapaya Specialty Hospital, one of the patient admitted assaulted the nurse. So these are the things. Anyway, any questions from the audience, please?
The India is facing challenge of 0.3% of psychiatrists, and until we increase it,
true, sir.
Your role in the court, I think, doesn't place. The reason is we are not able to treat the real patient here. So what is the plan of Indian Psychiatric Association regarding to increase your breed?
So, I mean, as I told, sir, there is a postdoctoral fellowship now in forensic psychiatry in NIMHANS.
No, I am
so,
not about forensic part, general.
Okay. So,
see what the methodology they are telling that introduced in telecommunication for PSCs. But can you assess that in through telecommunication?
Sir, I mean, a lot of our patients we can definitely see through telemedicine. So, the telemental health, National Telemental Health Program is, I think, picking up very well. So, NIMHANS had recently given some data. I forget the numbers and everything, sir. But, I mean, we also have telemedicine unit in our hospital. I'm sure a lot of other places also have. I mean, if it is pertaining to care of individuals, I would say confidently, 90-95% of our patients we can manage with telemedicine. So, only problem arises where a person refuses to take treatment. Then, there is no way we are going to handle it via telemedicine. And regarding the increase in the number, I completely agree with you. I mean, whatever increase in PG seats are there, they are nowhere near to the amount of burden. So the National Mental Health Survey, I think done in 2016 or something, says 14-15% of the population has some form of mental illness. So you can imagine with 1,000 psychiatrists, how are we going to handle it?
I recently read, just a couple of days back, on recent
True.
article.
Yeah. There is a huge mental health gap,
India
sir.
is struggling.
Yep.
ನಾನು ಹುಷಾರಿದ್ದು ಅಂತ ಹೇಳಿದ್ರೆ ಸರಿ ಇಲ್ಲ.
True. Yes.
Replacing the conventional treatment for them.
True, sir.
In Kerala also there are too many institutions, religious institutions are there, and they are denying the conventional treatment for them.
True. Actually, there is so much scrutiny, and all the psychiatrists are feeling paranoid because of the mental health care laws. But so many people are, actually they are abusing our patients by just withholding treatment. Scientific and evidence-based treatment itself is clear abuse of vulnerable set of people. So I hope the government and hopefully the ground implementation is much better. And yeah.
Sir, I have a small question, sir. It was a very wonderful presentation, very informative also. My question is on assessment of cognitive impairment. So since our knowledge is very limited in psychiatry, at this point of time we usually refer to mini-mental status examination, which is a scoring system. I just wanted to know how effective is this scale?
As I told madam, just because you get a score say lesser than 24 out of 30, I believe is abnormal, doesn't mean the person lacks capacity for certain tasks. For example, say if it is testamentary capacity. So a person may have a score which is in between 16 to 24. Lesser than 16, research is there which tells that there is a good possibility they may have impaired capacity, right? And also we know very well that if some cognitive dysfunction is there, it depends on, that's why we do that neuropsychological battery to see which are the brain areas which are affected. So there may be a certain set of injuries or a certain set of disorders which affect that part of the brain which does not affect the executive functions, for example. So he may have bouts of aggression because of the temporal lobe injury, but his frontal lobe may be intact and he may be able to organize these things in his mind that, okay, say for example for distributing his property, he may know everything. He may have aggression because of temporal lobe injury. So that doesn't mean lack of capacity. He may score less also because temporal lobe injury, there will be definitely some low MMSE score between say 16 to 24 also sometimes, but that doesn't mean there is lack of capacity. So the capacity assessment, unfortunately we don't have tools. The Western tool, I think something called as MacArthur competency assessment tool is there, mostly for clinical setting, and there are many other tools also to assess capacity. So hope we get some Indian adaptations so that we can use them, because just because they have cognitive dysfunction doesn't mean they lack capacity. That is the message that is important, I think. Yeah.
Sir,
yes.
2 questions will be asked simultaneously. One, does the psychiatrist look at his interaction with a person who is brought by police on a fiduciary basis? 2, can a person who has done an assessment of with regard to criminal responsibility with a person with whom I assume does not have a fiduciary relationship because he is brought by police, arrested or something, how does it reflect legally and ethically to share the details of your professional experience in media?
Oh, sir, sharing in media is wrong. That I think is one of the rights of mentally. I did not go through everything. So one is right for protection against making information about the patients available to the media. We have to be very careful. Actually, the patient has right for protection of such confidential information. Of course, if the as you told, if the police have come with a request for assessment, then we are always caught up in this ethical dilemma, especially we clinical psychiatrists. There are hardly any forensic psychiatrists. So yeah, so we are always caught up in this dilemma. But if we are sure that the police is going by the law and there is a request, proper request, then we will have to reveal certain confidential information. And it is nice to tell the patient that I am required by law to reveal these confidential information. Yeah. Torosov, yes sir. If we believe that there is harm to somebody because of a patient, we should report it, sir. We cannot say that it is yeah. Correct. True. Correct. Ideally, yes, we should do that, sir. True.
But you are just, you want to share with the media or the public your experience with criminals. This makes good television and you find a lot of people doing that.
Sir, if there is information that is public and as an expert I am analyzing it, I really don't think there is an ethical problem there, right? But if there is hardly any information and we see on TV how they hypothesize and then they start analyzing everything, which is true. Yeah.
You're chewing the cut on your glorious time you had with this opportunity.
True. No, in the question that you are raising, sir, I think it should not be discussed, because even if he is a criminal and he is facing a trial, he has his rights. He has his rights to. True. Yeah, these are all grey areas, sir, and unfortunately, our own fraternity sometimes cross a certain line. Yeah, yeah.
Sir, one.
I mean, his marathon running, I don't know, but I don't run marathons, sir.
Sir, one question from my side. Say a patient in the cultural context, there are a lot of possession syndromes happening. In such a scenario, if he commits a crime, what would be the take on such a crime?
Yeah, yeah. So, I mean, practical experience is very limited, Balchandra. As I told, when it comes to say criminal responsibility, I have not handled such cases, right? So, I mean, if we are able to establish that lack of reasoning and mens rea is not there, maybe the person may stand a chance, because there are some culture bound syndromes which are say described in the what's that called as Indonesia and the Malay countries, where a person goes into a rage attack, hurting, harming, stabbing people, and there are descriptions where the person definitely does not have the reasoning and doesn't understand what he is doing. But I am, I wouldn't say I am an expert. I have not studied such cases, and I don't know what the law has to tell.
I myself was once a victim of say post-ictal confusion. Patient had seizure. He come to the hospital to the emergency. After treatment, he suddenly started assaulting his mother. I went in between. I got a slap and my tympanic membrane got perforated. It was a grievous injury. But correct, he was not in his mental capacity.
Correct.
So, if that may be okay, one small incident, I thought it was a bad day. But if it is something like he has a weapon, or he himself commits suicide, or he has got a center line in place which he pulls out and he bleeds to death. So, in such scenarios in medical hospital also, who would be accountable? Tough situation because of a clinic, as a practitioner.
Yeah. Yeah.
It is not telling. But the question, sir, as you told, is it a curable? There is one more case, she is a dementia. Is there any, you are saying, patient comes with dementia. Is any dementia certified patient like that? Because the court given for a guardianship for 1 month. Correct. And after that again the patient was put it in the psychiatrist. Psychiatrist not answering anything, whether guardianship given for 1 more year. In such a situation, how will diagnose, sir? Whether it is a curable or not curable?
Sir, I mean, we cannot say that there is a cure for especially severe mental illnesses. That's why they ask this question. They want that from our mouth in front of the judge, that this person has an incurable illness. Because it's like if you ask about diabetes, there is no cure for diabetes. You can manage diabetes. So a lot of mental illnesses are managed. There is no way I can tell whether it is curable or not curable. But I mean, the lawyers catch hold of that and then use it to their advantage. Ideally speaking, we should not answer that question, I feel. If they are only asking, we should give a more nuanced answer. say for example, if it's a divorce case, I can tell exactly if there is, how is the severity of the illness, whether those symptoms are actually impacting marital life, whether there is functional disability, whether this person can fulfill roles and responsibilities. We should give a more nuanced explanation. And regarding dementia, as I told, I think that RPWD Act talks about limited guardianship and all that. So, I mean, if we can establish, no matter how severe or mild severity or whatever of dementia, if we are able to establish that the person does not have the competence to make legal decisions, the decision making capacity is impacted. So it's again capacity assessment in some form. If there is no capacity, then definitely legal guardianship, limited guardianship can be requested by the family. And Balachandra's question, I don't have any answer. I mean, about the pulling of the catheter and all that.
We will wind up the session.
Thank you very much.
Thank you very much, sir, for this wonderful session. I request the chairpersons to felicitate Dr. Ravichandra Karkal with a memento and a certificate as a token of appreciation and gratitude. I now invite Dr. Venkat Krishna Shenoy to felicitate the chairpersons of this session. Thank you very much, sir. We'll now be breaking for lunch. The next session's time will be intimated soon. Thank you. Welcome back, delegates. Our next session will begin now. The next guest speech will be chaired by Dr. Lisa John, who is a professor and head of the Department of Forensic Medicine and Toxicology from Government Medical College, Ernakulam, and Dr. Vimal Vijay, who is a consultant in Government Hospital, Thrissur. We welcome you, ma'am and sir. The guest speaker for this session is Dr. Smita Rani, who is an associate professor in the Department of Forensic Medicine and Toxicology in JSS Medical College, Mysore. We welcome you, ma'am.
Let me introduce Dr. Smita Rani, Associate Professor, Department of Forensic Medicine and Toxicology, JSS Medical College, Mysuru. Dr. Smita Rani is a forensic medicine expert, academician and researcher with experience in medico-legal investigations in forensic toxicology and medical education. Currently serving as an Associate Professor in Department of Forensic Medicine and Toxicology at JSS Medical College. She completed MD in Forensic Medicine in JSS Medical College, Mysuru, MBBS from Father Muller's Medical College. Welcome you.
Thank you. First and foremost, I would like to thank the organizers for giving me this opportunity to share my experience, whatever little I have, in front of this August forum. To begin with, I would like to quote Sir Matthew Hale, who said, "Rape is an accusation easily to be made and hard to be proved, and harder to be defended by the party accused, though never so innocent." So this age-old observation actually points out the delicate balance which is required for safeguarding the rights of the survivor, meanwhile protecting the accused from wrongful allegation. So what would be the modern medico-legal practice aligned to is, the first thing is the scientific accuracy with which we report. The second thing is ethical sensitivity whenever we are dealing with such cases, and also it is important that whatever protocols are there in place, it has to be implemented with rigor. So then only we can provide justice for all people involved. So with this, I would like to step in the presentation for today, which is challenges in examination of sexual offense survivor. So before moving on to the challenges, I would like to put out a disclaimer saying that there are few cases which I would like to quote in this presentation. The only reason why I am quoting these cases is just for enhancing our understanding as to how one has to do such examination, and I believe that the audience here will take this information with professionalism, compassion and confidentiality which it deserves. Coming to the session objectives, initially I'll be putting up certain definitions which has to be known if you have to do the examination. So introduction to the sexual assault types. There are two terminologies which is usually used when we are referring to a person who has undergone the whole assault or abuse. So the two terminologies is victim and survivor. So we'll also try to know whether these two terms are synonymous with one another or is there any distinction between the two terms. And then we'll move on to the expected protocol and what are the challenges involved, starting from the operational issues to the framing of medical opinion. So this is the framework for today's presentation. So coming to the introduction, so what exactly is sexual assault? In general terms, if you define sexual assault, it is a behavior which is threatening, violent or coercive, to which a person has not given consent or was not in the position to give consent. So the usual belief whenever we hear the term sexual assault is people think that it is just penetrative act, but it is not so. It is a range of non-consensual sexual acts. So it could be from unwanted touching or fondling of private parts also might include penetration. So coming to the types of sexual assault broadly could be classified as penetrative and non-penetrative sexual assaults. If you have to talk about the legal definitions, we have the legal definition for both penetrative and the only sexual assault in the POCSO Act. So I'll just briefly give you an overview of what these acts say about the sexual assault. So coming to the definition of penetrative sexual assault, which is given in section 3 of POCSO, it says that any kind of penetration into the oral, mouth, anus of a woman, manipulation of the body parts, applying the mouth, insertion of object. So all those things would constitute as a sexual assault. The same broad meaning is there even in section 63 of BNS. Now coming to the sexual assault per se. So sexual assault per se is wherever with the sexual intention there is a touching of private part, or any act which is done with the sexual intent would come under the purview of section 7 of POCSO. And there are other sections here. Again, section 11 of POCSO talks about sexual harassment of a child. And if you look at the BNS, the section 74 to 77 of BNS deals with all of these. Like 74 talks about sexual harassment, 75 talks about if a particular act is outraging the modesty of a woman, 76 talks about disrobing, and 77 talks about voyeurism. So this is just an overview. So why it is required for a doctor to know what to do in such circumstances? If you look at the statistics also, if I have to take or talk about the recent statistics in our state, it is said that per day about 10 cases of POCSO are reported. So it is even more important that each of the doctors are aware of what to do and what not to do. So now coming to the terms used, we have two terms which are used when we are referring to a person who has gone through this, either the victim or we also use the term survivor. So let us know whether these two terms are synonymous with one another or is there any difference. So whenever we are talking about such examination, these two guidelines are something which we look up to. One of the guidelines is the Ministry of Health and Family Welfare guideline, which came up in the year 2014. If you look at this guideline, it uses the term both survivor and victim. Whereas if you look at the Kerala protocol of 2019, where it is a protocol given by Government of Kerala for examination, so they use the word survivor. So now let us see what is the difference between the two. So when you say victim I would say is more of a legal term, because even if you look at section 2Y of BNSS, it defines victim. So who is a victim? Victim is somebody who has suffered any loss or injury because of the act or omission by an accused. So this is the legal definition. So victim per se becomes a legal term. Whereas survivor, if you're using the term survivor, it is a term usually portraying that you're supporting. So it is a term of advocacy. So survivor is a term which impacts or means empowering. So basically it means that that person, despite of being suffered all this victimization and humiliation, still the person is capable of taking decisions. So I would say survivor is a better term to be used even when we are documenting in such examination. So now coming to the procedural aspects, the first one which I would want to talk about is the operational issues involved whenever we are examining such individual. So now how can a survivor present to a health setup? So the expected ways in which they would present, three circumstances could be there. Either she would present self to a hospital setup, or she could be referred by the police or through the court. So these are the three ways in which a survivor could approach the health facility. So once the survivor approaches, the three things irrespective of whether you are a private or a doctor who is working in a government setup, these three things are needed to be done. The first one is the immediate treatment, which is told in section 397 of BNSS, which categorically mentions that the treatment has to be given and it has to be free of cost. The second thing is mandatory medical examination. Here again, the doctor cannot refuse the examination of a survivor. The third thing is police intimation. I think enough has been discussed already over the last 2 days as to what should be done. So I'm not going to go in detail about that. Police information or intimation is a must. And the second point which I have to stress on here is we do not wait for the police to arrive to complete the examination part. So these are the three things which one should take care whenever a survivor approaches. Recently we saw in news somewhere in February this year. So there was a particular news article which said in Uttar Pradesh there were 2 sexual abuse victims, both in their 20s, and the doctor who was on duty on that day was a male doctor. and these victims said that they don't want to undergo the examination. So now what does the law say about the gender of the examiner? So now if you look at the BNSS, which is a section which deals with the examination of a victim, it does not mention the gender of the examiner. It just says registered medical practitioner can examine. Now who is a registered medical practitioner? Again, that is given in section 51 of BNSS. It says that registered medical practitioner is any person who has the required qualification which is accepted by NMC Act of 2019. So this is the definition of registered medical practitioner, and his name has to be registered in the State Medical Council or the National Medical Council. But if you look up to the section with respect to POXO, section 27 of POXO categorically mentions if the survivor is a child, then the examination has to be done by the lady medical officer. Now what does our guidelines say? So two guidelines which I've earlier mentioned. One is the Ministry of Health and Family Welfare guidelines. Here also it mentions that examination, if it is a female survivor, should be preferably done by a female doctor. Now the Kerala protocol goes one step further, and it says that if it is a female survivor who has been subjected to vaginal penetrative sexual assault, and if she happens to come to the hospital within 96 hours of such assault, then a women gynecologist, if on duty, so it is stressed upon here, if there is a women gynecologist who is available in this particular setup, then she has to do the examination. If such examiners are not available, then what to do? Then any lady medical officer can examine. Now this particular thing was questioned by someone in the Kerala High Court also, and what Kerala High Court told is it upheld the ruling that gynecologists should examine if they are available. So it doesn't mean that the other doctors are not competent enough for examining. So why did they say the gynecologist has to be there? The reason here is they said that whenever it is a vaginal penetrative sexual assault, it is not just about examination and evidence collection. There could be life-saving treatment aspects also which could be there, and they felt that a specialist would be better placed in handling those. So this is about the choice of examiner. So even when it is a transgender survivor who has to examine, here the examiner should be based on the preference of the survivor. So they are given the choice of deciding who should examine. Now these are the expected procedures. Now if you look at the procedure, what is a challenge here? One of the challenge, especially in a rural setup or remote setup, is the examiner availability itself. So when you are telling that it should be a lady examiner, when it is within 96 hours, if it has to be a gynecologist, not all remote places will have those examiners. So now possible solutions according to me for this particular challenge is on-call roster system could be followed. Suppose if there are certain cases which are brought in, you could have an on-call roster system which says that if such case comes in, then this person can come only when the case comes. So that could be done. And when there's a specific trained officers are not available in a private or a remote setup, what could be an alternate solution for this is telementoring or remote guidance. Otherwise also, whenever we have doubt, we do call our seniors to ask what to be done. So this could be put up as an SOP only. So telementoring, or it could be a remote guidance. Policy support in terms of recruiting the required staff also is important, and however is told or about the specialist requirement, basic training especially in Indian setup is very important for all medical offices. At least we can maintain the minimum standard of care which is required in such cases. Now coming to the next challenge which I perceive in terms of the operational issue again is sometimes the SOPs which are followed in a particular hospital may not be on the same page as the judicial expectation. So this I want to quote one of our experience at JSS hospital. We have something called as child abuse response unit. So basically whenever we have any child survivor brought in for the examination in cases of sexual assault, it is done by a group of doctors, and this child abuse response unit has members from OBG, pediatrics, then there is psychiatrist, and then there is a forensic medicine specialist. So one such case where a child was jointly examined by all of these people who are the members of this particular Child Abuse Response Unit. However, the final report was then signed only by the forensic expert. So now, when this case came up in the court, the issue raised there was why had the OBG specialist not co-signed. So they didn't ask why they didn't sign. They asked, you're saying there is a response unit in your hospital. If the 4 doctors are examining, why not them signing the report also? I think it was the right question to be asked there. So they felt that the specialist would be better placed to answer the questions related to hospital stay and follow-up aspects. So now the possible solution here, I'm not saying that the forensic expert is not competent enough to examine or give the report in such circumstances, but my take is co-signature by whoever concerned, who have examined, would I think would improve the credibility and clarity of the reports which we give. And after that particular case, we had certain tweaking of SOP. Now the cases what is handled by CARO all signed, but when it comes to court, the forensic representative goes to the court, and that is accepted also. Now coming to the consent and related issues when it comes to sexual assault survivor examination. Now the expected procedure here, the survivor should give written consent for examination. So this is as good as any medical examination. We cannot examine anybody without consent. So now section 184 subclause 7 of BNSS categorically points out that whatever the examination part is, it has to be within the scope of consent. So what does it mean? For example, I have taken consent for examination and evidence collection. During the examination, I see there are bite marks on the body, and I feel that photographs would be required, so I happen to take the photograph. But there in your consent, if that issue is not mentioned, because there are certain case which we had experienced which went against the doctor when the photograph was taken and that was not mentioned in the consent part. So these things are there. So whatever we do, we have to have consent for what we do. The next is the minimum age part of age of consent. What is the minimum age of consent for medical examination? If you look at the provisions of 27 and 25 BNS, and if you refer that, then the age of consent becomes 12. Okay. The same thing is given even in the Ministry of Health and Family Welfare Protocol, which says that if the child is below 12 years, you take consent from the guardian or the parent. Above 12 years, you take consent from the survivor per se. But here there is a little bit of difference in the protocols available. If you look at the Kerala protocol, it says that if the survivor is below 18 years of age, you take consent from the parent or the guardian. Okay, so this is given there. So now they have given the explanation also why you have to take consent from parent or guardian when the child is below 18. So their explanation goes like this. So if you know POCSO section 2D, it says that child is anybody who is under 18. Okay, whereas section 41 of POCSO states that section 3 to 13, these are basically sections which criminalizes sexual offences against children, do not apply if the medical examination or treatment part is done with the consent of the parent or the guardian. Okay, now you have a legal inconsistency here. What does BNS say? A child above 12 may give consent for medical examination, whereas under POCSO, if you interpret, a person below 18 must have parental consent, or else the act could be interpreted as sexual assault even if the examination is purely medical. Okay. So now although we have protocols, there are difference in guidelines. So now the first challenge which I want to put is this per se, there is legal inconsistencies in consent age. The second aspect is whom should we take consent from when it is a vulnerable adult sexual assault cases. One such case of our experience I would quote in my future slide, and what to do when the survivor is refusing or withdrawing the consent. So now talking about the first thing, whenever there is the scenario where the parent is consenting, the child is not consenting. That happens often. So what I would say is whatever is legally right may not be ethically right too. Okay. So now I will explore what to be legally right and what is not ethically right, giving 3 scenarios here. The first scenario is parent consenting, child assenting. So now here there is no problem. The parent is also agreeing, child is also giving the assent. So both legally and ethically you are right if you are examining. The second scenario is the parent consents but the child refuses. So legally speaking, you are right to examine because the parent has given consent. But ethically, it is something to proceed with caution. So in such circumstances, what could be done? One of the option here is, anyways, the POCSO mandates that a trustworthy person should be there when we are doing the entire procedure of examination. We could take into confidence that person and trying to explain the child why this is important to be done, okay, and then only we could proceed. Then child assents, parents refuses. So obviously legally it is not right, and ethically we also cannot proceed in such circumstance. Okay, so this is about the different scenarios. So now you could ask what to follow, the Ministry of Health or Family Welfare guidelines or the guidelines, the Kerala protocol. So now again the same handbook mentions that the special law would prevail over the general law. So it is always better to stick on to the special law when it comes to the age aspects. Now assess if parent consent is at the child's best interest. Need not be always, especially when it is a child survivor. Most of the times the accused could be somebody who is known to the family, and that is the reason sometimes the parent may not act in the best interest of the child. So if you are suspecting that, what could be done? You could inform the child welfare committee there, and also ensure that a trusted person is there during the entire procedure of examination, which is given as per section 27 of POCSO. Now the second challenge which I put was consent aspect again in a vulnerable adult sexual assault case. So this is one such case which we had examined. The background of this case was the survivor was actually a mentally ill patient. She was admitted in a destitute ward in a particular hospital. Okay, and this particular alleged sexual assault happened in the premises of the hospital. And the request we got was after 10 days, and this was the second examination request which the police asked, and already the first examination was been done by another center. So now there are two questions here. Is the second examination justified in this particular case when already a competent doctor has examined, that too after 10 days? The second question is whom to take consent from. Now she's a destitute, okay, so obviously there is no parent or guardian to give consent, and the person is an adult but mentally challenged. So now what does the guidelines say here? In the absence of the parent or the guardian, and if it is not a child, then the panel of doctors has to be constituted in the hospital, and they can take the call on to whether to give the consent or no. Okay, this is as per the Ministry of Health and Family Welfare guidelines, or the jurisdictional court could take a decision. Now with respect to second examination after 10 days, so here again what I would want to say is, it is not necessary that all requests which the police comes up with, we have to accept it, unless it has a scientific justification. So here I feel that repeat examination is not something which is forensically justified. Okay, so hence we tried to explain the same to the IO, and they agreed, and we didn't do the second examination here. Now coming to the refusal part and withdrawal of consent part, if you look at the health and family welfare guidelines, both consent and refusal are taken in the same format, but we usually don't follow this. Here they mentioned that there are three aspects of consent for examination. Survivor can consent just for medical examination. She may not consent for the evidence collection, and she may not, or there are other scenarios where sample collection is okay, but she does not want to inform the police. So that is out of this one, we have to inform if we come to know. Okay, but in intimation you can say that there is a refusal for her to intimate, but we have to inform the police. Now what we practice is, whenever there is a refusal, we mention that in the report, that she has refused for the examination. Along with that, we also have take a written document from her alleging or telling that she is not consenting for the examination. So this is just for the explanation I've just put here. Certain written requests which are given by the victim for not undergoing medical examination. So this is in addition to the signature which we take on the form. Okay, so this is about the informed refusal part. So this has been written in the handwriting of the survivor. Now coming to the examination part, what are the challenges? So now I'm not going to go in detail of what has to be done in each of these steps. If you refer to any of the guidelines, it is very clear as to what to be done in each of these. So starting from the first aid till the legal support, it is nicely explained in both of the protocols. So now the initial step is recording the personal data, entry of date and time of examination, who has requested, and history. So here I have to stress on the history part. So whenever we are seeking the history, we have to record it in detail because that has corroborative value in the court of law, even when your examination is not going to yield any fruitful results. So history part, one has to give some time and try to elicit the history in detail in survivor's own words. Along with that, you could take history about the actual act also, because that becomes relevant for me as to what I should collect in this case. So that is also very relevant in history. And when I'm examining, what one has to keep in mind is that not all the cases should have injuries. So if you look at only 1/3 of the cases of forceful sexual intercourse will have injuries. So then there is lot of importance which is given to hymenal examination, but I feel that presence or absence of hymen injury is not indicative of anything. Okay, so the rape could be committed even when a person has inability to perform a sexual intercourse or produce erection, and even a slightest penetration as per the recent amendment, it is considered to be as rape. So completed act of intercourse is not actually necessary. So there is lot of myth which is associated with the hymen, that is presence or absence of hymen can prove. Actually it does not or need not indicate anything with respect to consensual or non-consensual intercourse. And the other myth is, if I am doing the hymenal examination, I can determine whether the sexual assault is non-consensual penetration. Actually we cannot do anything based on the hymenal appearance. What is important is more of corroboration with respect to the history which we get, other forms of evidences which we collect during the examination. So that is more important to draw the medical or legal conclusion, and not just the hymen examination. So now this initially in 2012 itself, the Supreme Court said that the two-finger test should not be done. In spite of that, there are many instances where the two-finger test has been done. So that is the reason why Supreme Court again in 2022 said that if somebody is doing the two-finger test, the so-called two-finger test to know whether the particular survivor is virgin or no, then that could amount to misconduct. So this was in 2022. So now, for victim examination, there are two things which one has to keep handy. One is the Ministry of Health and Family Welfare guidelines. The other one is the safe kit. Even if you are doing the examination for the first time, if you have these two things in hand, it is very easy to go about. With respect to safe kit, there are many vendors also who provide the complete safe kit with the guidelines as to what to do. Even if you don't have one, it is very easy. If you know the steps, you can easily conduct the examination. So I'm not going to go in detail of what to be done, what has to be collected. It is a 14-step examination. One could easily access this particular information from any of those guidelines. So what I have to stress here is, whenever we are taking the pelvic hair combing, okay, we use the comb. Then for the nail clippings, we use the nail cutters. So remember that these are one-time use ones. So you cannot use the same for the next person also. Why we cannot use the same, I'll come to it a little later. And if you're using the forceps and the scissors, they could be sterilized and reused. So this is the step in case of safe kit use, and there are vials also, and it is mentioned what to be collected for what. If it is a red packet, it is for blood grouping and drug estimation. Purple is for DNA, and the gray is for the alcohol estimation. So now the second part is, we have done with the examination evidence collection. Should we do the age estimation for all cases? Not required. So this again has been told in the Supreme Court judgment in Ashwini Kumar Saxena versus State of MP. It is not necessary for medical examination for age in all survivors unless it is disputed. Okay, so this is the thing. And if suppose the survivor is pregnant, so then it is a ground for abortion. Again, consent has to be taken from the woman if she is above 18. If it is a minor or a mentally incapacitated, then the consent has to be obtained from the guardian, and MTP could be performed as per the recent amendment up till 24 weeks. Now when we are doing this, we also have to make sure that the product of conception is preserved. What could be used? Sterile normal saline could be used 0.9%, and the chain of custody has to be maintained appropriately. It could be refrigerated at 4 degrees Celsius. In certain circumstances, we might also get a request from the court to come and collect the blood in front of the magistrate. So such request also we do get, where the request for blood collection is under court supervision, for which we might have to go to the court and collect the required evidence. Now, what are the challenges here? So now there are 4 challenges which I would like to list in examination and evidence collection. The first challenge here is sometimes, especially in POXO cases, our examination might suggest that it could be a case of sexual assault, but there is no history given. Okay, history is not given or history is not forthcoming. Then what to do? Should we send a police intimation or no? Okay, so this is the first question. Then the other challenges is when there is delay in reporting, the whole examination, even if you do properly, there may not be any positive thing which comes out from the examination. Then there is also a contamination risk when we are doing the evidence collection, and inadequate training and infrastructure is also one of the challenge when we talk about examination and evidence collection. So let us address each of these challenges. So what to do when there is no history but there is finding suggestive. So patient presents, history is not disclosed, but your physical findings suggests of assault, then I would say the police intimation has to be sent. Send police intimation. If the consent is given, then you can go ahead and collect the evidences. If the consent is not given or refused, then obviously we cannot do the evidence collection. The next is why I had said that if there is a delay in reporting, it itself is a challenge, because whatever biological evidences we collect, it is time bound. So there is an optimal time frame within which we have to collect these evidences. So this I have taken from my reference for this is National Best Practice for Sexual Assault Kids, which has given an optimal time frame for collection of evidences. Suppose if it is a vaginal penetrative sexual act, the optimal time frame they say is 5 days. For anal intercourse it is 3 days. For oral it is 1 day. For saliva, that is the bite mark, if you want to collect the saliva swab, that is 4 days. So this is the optimal time. What Ministry of Health and Family Guidelines says, up to 96 hours. If the female comes in or the survivor comes in, you can collect the evidences. So that is why the delay in reporting is itself a challenge when you are framing your opinion. It is not enough if you just collect the evidence. It is also important how you collect the evidence. So for this I would want to quote this particular case, the Phantom of Heilbronn. Heilbronn is a place in Germany. So here what had happened in this particular case is, more than 40 plus crime scenes, a DNA of an unknown woman was found, and all of these crimes were committed over 15 years. And what the investigating authority suspected or believed that there must be some female serial killer who was involved in all those 40 cases. But later they found out that what was wrong there was actually a cotton swab which was contaminated at the factory itself, production time. And that is the reason why there was a third person in all those 40 crime scenes. So the takeaway here is ensure DNA free certified materials are used for evidence collection to avoid false leads. So it is not something very historic. Even if you take the recent case which was in limelight, that is Ajikar rape and murder case. So here also there was improperly controlled evidence collection, which even the judge observed in the judgment. So what has actually happened is, one of the nipple swab which the doctors had collected had a female DNA not belonging to the victim. Okay, and what was observed that it was likely because of contamination during the postmortem examination, possibly because of the use of unsterile instruments or shared swabs. So that is the reason why we have to maintain even the chain of custody, and evidence collection also has to be with the protocol, okay, and make sure that such faults don't occur. So possible solutions for the challenges which I have listed. The first one is educating on importance of early reporting, providing the required infrastructure, especially the use of DNA free certified kits whenever possible, and trained personnel. I think Dr. Ashmi Kumar had mentioned in his talk about same programs which at present are not available in India. I think that is one of the good stuff which we can invest in, so that you have a best trained support, because most of the evidences after it is collected is handled by the support staff. Now, challenges in framing the medical opinion is the last point which I want to stress. Here, all of us know that rape is more of a legal term. It is not a medical diagnosis, and absence of findings doesn't mean that the rape was not committed. Rape was not committed. So, no body injuries or genital injuries also does not rule out anything. So, no evidence of intercourse doesn't negate the possibility of rape, and and one of the main limitation I would say is, your definition says that manipulation of body parts is also rape, but that is something which cannot be proved by medical examination. So extent of penetration or manipulation often cannot be medically proven, and here medical examination may not confirm the non-penetrative sexual acts also. So all of these are limitations. Why there could be absence of injuries? There are many reasons why injuries are not there. Either the survivor is not in a position to offer resistance, could be because of intoxication, could be because of threat, or the delay in reporting per se is the reason why there is absence of injury. Or what is the reason that FSL has come negative? Here also there may not be actual ejection or ejaculation there, or the activities like cleaning self or washing clothes also would be the reason why the reports would be negative. Now coming to the possible solutions here with respect to examination and evidence collection, the use of standardized medico-legal templates. If you look at the family welfare guidelines, it itself gives you a list what to write as opinion. If genital injuries are present, physical injuries are present, what should be the opinion? So the entire guideline is there. There is a tabular column which is could be easily referred when you are framing the opinion. And it is also necessary for us to understand that medical evidence is not mandatory for conviction in sexual assault cases. For this, I would like to quote one of our experience. Here, this was a particular case of delayed disclosure in a child sexual abuse. The background of this case was there was a minor who disclosed of repeated sexual assault for the over past 3 years in one of the school-based awareness program which is conducted. And post this, she also reported that there were multiple acts of penetrative sexual intercourse, and she did not reveal it to anybody because there were threats to her life. So because this examination was done after 12 days after the alleged last act, and also she had washed the clothes and all of that, there was no forensic evidences to prove or disprove it. But still in that particular case, the court convicted the accused there. So the take-home message here is conviction is possible even in the absence of medical evidence. So based on consistent history, credible testimony and supporting circumstantial evidence. So it is not necessary always that the medical evidence should prove that. So now this same thing has been also told in state of Karnataka versus S. Raju case, that corroboration with medical reports is not necessary in every case. So to conclude, I would say that normal examination findings neither refute or confirm whether the sexual offense has occurred, and collection of evidentiary materials requirement as per the guidelines is up till 96 hours. In our practice, we collect till 7 days, and clothes we collect after that also if it is not washed. And delayed medical examination will not yield most of the times conclusive evidence. So to end, I would like to quote Bernard Knight, who said, "The role of expert witness is not to provide the evidence which supports the case for the Crown, nor the defense, unless the opinion is objectively reached and has scientific validity." I think most of our reporting, when we are doing the reporting, one thing we have to keep in mind is we should not be influenced with emotions, because most of the times there are females who come up or tell the stories which may not be true also. So emotions should be kept aside. External pressure should be kept aside, okay? Only then you could come up with the right opinion. So these are my references which I would referred for this particular topic, and I would like to acknowledge the intellectual inputs from Dr. Arun M., who is professor in the department, Dr. Chinmay Y., who was my colleague, earlier member of Child Abuse Response Unit. Few of the cases are her experience. I also like to thank Dr. Akshit Raj Shetty from Ramaya Medical College, who had guided with a framework for this presentation, and Dr. Nanda Manoranjan, who is my postgraduate, for fetching the files. Few cases were very old. So I acknowledge all their support for this presentation, and thank you for the patient hearing.
In fact, it was a very vivid picture you are given us regarding the necessity of doing an examination in a survivor. Actually, there is one query inside. We are referring much of this from the medico-legal protocol code we practice in Kerala. There is based on few challenges which we definitely do in our day-to-day practice. There is one scenario where you were citing that parents may consent, may not consent, but the child may assent immediately, whatever it is, if, whether to proceed or not. There is a bit of a open question.
Yes.
A lot of dilemmas come from our examination gynecologists. Lot of calls come to us. Should we proceed? What we think is that we have to proceed. There is need. Doctor should mandatorily proceed with the examination. Wait and convince. Since it's the need of the hour, golden hour shouldn't be missed. I think that anybody below 18.
Below 18, the question is if she is below 18, as per the CREDA protocol, it said that.
Yeah, it was.
Yeah.
Can you just take
Yeah,
this? Right?
right.
That I think many of the people are under confusion whether should we do or not. Should not. So Krishna, wait.
So these are the three scenarios which I had put actually. Parent consent, child essence is.
Parent doesn't. The question is, parents are not consenting because should do. That is what we should do. No, what?
No, the second one what I said was parent consents, child refuses.
We are talking about third scenario.
Third one, no, child essence, parent refuses.
You are written, do not proceed, but we should proceed.
But
we should. Why?
Because legally.
It's not. No, it is. Perpetrator.
Below 18 years.
Sir, my perpetrator, yes.
Yes.
It is your decision.
Yeah, if suppose we feel that the parent is doing this because with the vested interest, so that is the reason why I put in the subsequent style that you have to assess whether parental consent is in the child's best
To be
interest.
frank, yesterday Krishnan was like many people were telling about the consent. This consent, unlike the other consent, it is not a consent where we should go by legally.
Yes.
Our objective is to derive, and we have to somehow conduct the examination where that scenario, that is, we will discuss. Child. And the doctor should be successful and competent enough to get some evidence to help him or her. That is your objective. So wait till, that is the second scenario. We can wait, convince, call the CWC, seek help. There is no hurry.
Yes.
We can hold even from you, please, you child, wait. Then your competency, you are a skilled doctor when you overcome that situation. But the last thing, that is what only thing we should.
Agreed.
And I think we are all, amen.
About the consent, I think when we say 12 till 12 years age for consent, that is for general examination alone. It does not involve genitals or with those examinations that are invasive. And examination of genitals, collecting swab is counted as an invasive examination for which you have to be 18.
18.
So 12 is not enough to say that 12 is an age where they can consent. And that's
General examination. Yes, sir. So that is the reason why I said that, 18 should be the one because the special law always has a prevail over a general law. Yes.
And inform child welfare committee.
Yes, sir.
And if the person is infant, if the child is infant, then I think there is provision to use anesthesia
for the examination.
For examination, in order to collect evidences. If the child is not permitting to collect the evidences, even if in such situation you can use the anesthesia for the betterment of the yes.
Actually, these are the real challenges which we face. As you told, there is a year-long conventional obsolete practice, two-finger test, which I think that Indra Kandekar has went into the court and swear. It is in fact a very good. Then opinion writing. You have exclusively you have thrown insight to the people where people think that hymen the status of the hymen has so much of role. Nothing to say that. And the most cornerstone, I think, in the POCSO examination is history, eliciting the history. That is the most difficult part. You can take time. That is the diagnosis, half of the diagnosis will be done there.
That is what ma'am was also expressing. Sometimes the words when we ask, the child may not be knowing. So the real challenge there is how exactly to elicit history from the child. So there are a lot of education materials which is available from the UNICEF website itself with respect to how to elicit this. There are certain pictures also available so that we can use those materials when it comes to
And in fact
history.
now in our CBME curriculum, in we are training the students, there is a competency one, how to elicit history taking and to proceed and consent acquiring in such scenarios.
Yes.
Then one more.
Safe kits, sir. We are doing a DIY. Yes, sir. So we don't. Yes, sir. So the private. Yes, sir. So I am aware of those kits, sir. But at present, in our center, we are using DIY. That is our own kits. We are having. We are not using those kits for examination. So what I went through is that when we are procuring like privately, each kit amounts to around 4,500 rupees. Private setup. If we are buying it as such.
Free of cost, it is.
The government.
One more scenario, you are a tie-and-tie situation when there is no female doctor to examine a girl, survivor. You were just, Madam, you were just mentioning, you wait till for any other.
No, we need not wait for that.
You call for any other on-call doctor who is, in case you don't find anyone on duty, can you proceed in the presence of a male doctor, but stand by, say, a nurse or someone who is, you can take the victim or the survivor is in confident or safe in their presence. I think we can proceed with that. Usually a common scenario where everybody go in for a confusion. Yes.
Yes, true. Yes, true. Yes, ma'am.
Nice presentation.
Thank you, sir.
We had a situation, madam. Just a 22-week-old pregnancy came for MTP. So we informed it as a POCSO case, 17-year-old lady with 22 weeks pregnancy. Then the Child Protection Committee said, no, private hospital cannot do it, the MTP. You have to shift it to government hospital. There, the MTP has to be conducted. Is it true, madam?
No.
A girl admitted in private hospital. No, they voluntarily came to our hospital for termination of pregnancy. MTP. She came for MTP because 17 years we informed the police. Then immediately police and Child Protection Committee came. No, this lady has to be shifted to government hospital where there we will do the MTP. You cannot do MTP. That's what they say. I don't know whether it is true or not.
It means.
I think no, there is a huge dichotomy between government and private. Unless we have an in-depth discussion and a policy, this muddle is going to continue. They bring us for sexual assault examination. When we collect evidence, they again take them to
government.
Yes. Then we have evidence. What about that? We have collected. Then after next day or a Sunday intervening 48 hours later elsewhere, does that even make a sense? So the question is, we need to question this particular status of a police thinking about it. Is it his limited knowledge? There's something called a Dunning-Kruger effect. I think we all must look up what is a Dunning-Kruger effect. with your very limited knowledge, you try to extend it in all directions and you act as an expert, and there are things that are written and followed, it becomes a culture, they're propagated. And that's exactly what is happening with the government services being made available. Then private colleges were very few in number. Today they have competency, they have much more staff, well equipped, and much more things happening than the government. I'm sorry to say, I don't discriminate, but in reality the aims related and which are coming up now, not even 40 to 50% staffed. While having said that, the truth remains, the services provided by anybody should be accepted without a pinch of salt, because they are equal.
So there's no more question, then we can wind.
Material, how long it can be preserved? It is not mentioned in the...
Yes, sir. Even the MH...
and how it is preserved?
So how is it preserved is mentioned in FSL guidelines,
saline
sir.
is not enough to preserve such a...
Refrigeration in 4 degrees Celsius.
I think it is in cryo...
Till. So that is as per FSL Chandigarh guidelines, sir, what I have quoted there.
There is a government, there is a High Court order, and Kerala government has issued an order to all hospitals to preserve this material.
Sir,
but how?
After the preservation, we have to intimate the police, and police will take it to the forensic science lab.
Immediately is what is mentioned.
No immediate action is carried out. There is no guidelines for the immediate action. How the police proceed after collecting this material?
Sir, collection of the evidence and sending, it's our duty, so it has to be
send it to the court, send it to the forensic laboratory will be studied with this material.
So I think the section can be concluded when if there is no more questions. And it is a very superb, awesome presentation.
Thank you very much, ma'am, for this wonderful guest speech. I'm sure this would have provoked a lot of thoughts amongst us. I now request the chairpersons to felicitate Dr. Smita Ranima with a token of gratitude of a memento and a certificate. I now request Dr. Kishore Kumar sir to felicitate the chairpersons with a memento and a certificate as a token of gratitude. Thank you very much, sir. We'll now be moving on to the valedictory function. I request all dignitaries to occupy their respective seats in the dais. Yes. A very good evening to our esteemed dignitaries, respected faculty members and dear delegates. It is with a sense of fulfillment and gratitude that we move on to the valedictory function of this distinguished gathering in Foryensicon 2025. As we draw close to the event, the ending of the event, let this not be seen as a conclusion but as a continuation of learning, collaboration and service to the field of forensic medicine. We will now begin this final session with the same spirit of respect and inspiration that has marked every moment of this conference. I humbly request Dr. Leena Pramod, Organizing Joint Secretary of Foryensicon 2025, to formally welcome the gathering.
A very good evening to all. On behalf of the organizing committee, I would like to welcome the chief guest of today's function, Dr. Abhay Nirgude, Dean Faculty of Medicine. I request our HOD, Dr. Shyam Kishore sir, to felicitate him. I also welcome the guest of honor for today's function, Mr. Amir Bawa, Finance Officer of Yenapaya Day2 University, to this valedictory function. I request Veena ma'am to kindly felicitate him. Thank you, sir. I would also like to welcome our distinguished guests, esteemed speakers, honored participants, dear colleagues and also KMC observer to this valedictory function of Foryensicon 2025, a two-day academic conclave that has brought together some of the finest minds in forensic medicine and medico-legal practice. Over the last 2 days, we have delved into impressive array of thought-provoking sessions, from handling medico-legal cases in day-to-day practice to the nuances of evidence deposition, from the intricacies of anesthetic or on-table deaths to the challenges in examination of sexual offense survivors. Each talk has left us more informed and more aware. We are truly grateful to our esteemed speakers who shed light on the critical themes like medical negligence, the role of allied health professionals, medico-legal aspects in psychiatry, and emerging concerns like LGBTQIA plus medico-legal issues in acceptance of otherification. This conference also hosted vibrant oral and poster presentation competition for undergraduates, postgraduates and faculty, sparking discussions and showcasing research excellence. We will soon know the winners of these competitions. As we stand at the end of this enriching journey, let us celebrate not just the language, not the knowledge gain, but also the spirit of collaboration and inquiry that Foryensicon 2025 has nurtured. Once again, a warm welcome to this closing ceremony. Let us make this finale as memorable as the beginning. Thank you.
Thank you very much, ma'am. May I now request Dr. Abhay Nirgude, Dean, Faculty of Medicine, Yenapaya Dean to be University, to formally address the gathering.
The guest of honor of this program, Finance Officer Amir Bawa sir, the organizing chairman, co-chairman Veena madam, and the organizing secretary Shyam Kishore sir, KMC Observer, and all the senior faculty members and dear delegates. It's 2 days of very wonderful interactive sessions. I got a feedback that the 166 participants, and I could witness the 10 minutes of intense discussion on the last session. So it's wonderful that all the medico-legal aspects has been discussed. Only thing I would like to suggest that due to such conferences we come meet, understand each other, we should take it forward as a collaborative academic, more academic events and more collaborative research to build on. So now in Yenapoya we have under medical college 3 implementation research where more than 6 institutes are part of it. So collaborative research will add value to the research also, and so such conferences should take it forward as a type of some academic exercises for the postgraduate or the research. Another one request, as a dean we face the problem of getting for forensic medicine faculty, so how we can attract more postgraduates and how we can increase the postgraduate academic so that number of seats, so that we'll get more and more expert hands. Thank you, and thanks for inviting me.
Thank you very much, sir. I take honor in inviting our guest of honor, Mr. Amir Bawa, to the function. Thank you very much, sir. Would you like to share some words? Thank you very much, sir. It's a pleasure to hear from you.
Well, being from the finance section, I don't know, what I could contribute to this session, I'm not sure, but probably something I could speak about cost. Might be if something, there's a cost saving which you can do. Something, that's probably the only thing, but I'm very honored to be here, and as a guest of honor, it's really very appreciative of Veena madam to having invited me for this function, and it's nice to see that so many people are there participating and interaction. That's very important for these kind of things, the interaction, the thought process. Somebody who has any ideas or anything which can be shared with others, I think that's really goes a long way in improving facilities and doing things. So that's all I would like to conclude my short talk. Thank you very much.
Thank you very much, sir. The end of an event is the beginning of better ones. We would greatly appreciate if some of our delegates could share their feedback. Your insights are invaluable in helping us organize future events better. I request volunteers may help transfer mic.
At the outset, I'd like to congratulate Team Yenapoya for a wonderful conference. Initially, there was a lot of hesitation from both Shyam and Kishore, and you should also be grateful to Suraj that we always backed. And the presentation what you chose was awesome. In my lifetime, I have never seen such a presentation on anesthetic deaths. Good. Yeah. And negligence. What always we see in forensic medicine conferences, talk about same direction, dereliction, same 4 Ds they'll be talking. And excellent presentation even from Sujit, where is he? He's not there. Okay. And anyway, we had a gala time, and it was wonderful. Anyway, madam's talk was there, Smita's was there, and our disability by today's, and psychiatry I could watch only couple of minutes. but excellent discussion we went on. So it was awesome and good hospitality from both our Kishore's dance was missing yesterday. Which usually extra points we usually get in all other conference, which was missing. Anyway, congratulations team NFIA Forensic Medicine. 3 cheers to you.
You're giving mic to the wrong person. I mean, I try to steer clear away from controversial statements because, I tend to make one after another. Anyway, I don't want to. I mean, that statement was enough for people to know what I'm referring to. Having said that, I would really like to congratulate Team Yanapoya, Kishore sir, Sham Kishore, and Veena ma'am. To dare to conduct a conference which is not under the banner of any society, and to conceptualize it in such short time. I think it was hardly 3.5 months, 2 months. So, and in between you had a change of the leadership. That's all. I mean, doesn't matter much, but still, in between all this, you pulled off such a great conference. I mean, sir has already spoken about the quality of guest lectures. I will not dwell into that, but to pull it off in such short time with all the hurdles that you have faced, I think you guys need extra applause than what you already got. Thank you.
Good evening, everyone. First of all, I was very thankful for attending the conference as a KMC observer. But as Mavale sir told, the topics, the lectures and the discussions were quite enormous. The last state conference was at my place, but compared to that, this was something else which was very good. I really appreciate it. Thank you.
Thank you very much everyone for your feedback. We will now move on to the prize distribution for oral and poster presentations. But firstly, I would like to thank our judges for the oral and poster presentation competitions under UG, PG as well as faculty categories. I request Dr. Vishal Kolhapur to felicitate the judges with a certificate of appreciation. I will call upon names. Dr. Nagesh KR, Dr. Unmesh AK, Dr. Mahabale Shetty, Dr. Lisa John, Dr. Ajay Balachandran, and now request Mr. Amir Bawa to hand over the certificate of appreciation to the remaining judges. Thank you, Dr. Vishal Kolhapur, sir. Next, I call upon Dr. Hanil D'Souza. Dr. Nikhil Lakshmanan. Dr. Varsha Shetty. Dr. Fauzia Hamid. And Dr. Rohit Gehlot. Thank you very much, sir. Moving on to the prize distribution, I'll be announcing the prizes from third prize to first prize. We'll start with the faculty paper presentation. The third prize goes to Dr. Rohit Gehlot, who is an assistant professor in Government Medical College, Kottayam. I request Dr. Abhay Nirgude sir to felicitate the prize to Dr. Rohit Gehlot. I request Dr. Abhay Nirgude to hand over the remaining of the prizes. The second prize goes to Dr. Muhammad Nasir Ahmed, who is the Associate Professor in Forensic Medicine Department of Yanapaya Medical College. The first prize is won by Dr. Harish S. Gowda, Professor and Head of the Department of Forensic Medicine, Father Mullas Medical College. Moving on to the faculty poster presentation, I request Dr. Shyam Kishore sir, Professor and Head of Department of Forensic Medicine, Yanapaya Medical College. Yes. The second prize is backed by Dr. Balachandra S. Bhatt, who is a professor in Yanapaya Medical College Hospital in the Department of General Medicine. The first prize is won by Dr. Veena J.S., Assistant Professor from PSG Institute of Medical Sciences and Research, Coimbatore. Thank you very much, sir. We'll move on to PG paper presentation. I request Dr. Veena Vaswani ma'am to award the winners. We'll start with the third prize. The third prize is won by Dr. Aishwarya Mohanan from KMC Manipal. The second prize is won by Dr. Zarina Begum from Hassan Institute of Medical Sciences. The first prize is won by Dr. Hima Vaswan from Government Medical College, Thrissur. ma'am. Next is the poster presentation under PG category. I request Dr. Kishore Kumar sir to hand over the prizes. The third prize is won by Dr. Aparna Sajeevan from Yanapaya Medical College. The second prize is won by Dr. Evelyn Judith from Bangalore Medical College and Research Institute. And the first prize is won by Dr. Vijay Anand from Sri B.M. Patil Medical College Hospital and Research Center, Vijaypura. Thank you very much, sir. The last one is the UG presentation. I request Dr. Venkat Krishna Shenoy and Mr. Amir Bawa together to hand over the prizes. We'll start with the third prize. The third prize, sir? Yes, sir. The third prize is won by Diti Shetty from AJ Institute of Medical Sciences. The second prize is won by Ritvika from AJ Institute of Medical Sciences. And the first prize is won by Sandhya Krishna Kumar from Adi Chunchandgiri Institute of Medical Sciences, Belur. Thank you very much, sir. Thank you very much, sir. This concludes the prize distribution. Thank you and congratulations to all the winners. I now call upon Dr. Muhammad Nasir Ahmed to deliver the vote of thanks.
A very good evening to all of you. This task, which everybody wants to finish. So it is my pleasure to say vote of thanks. And as my Mahabali Sethi sir said, few other dignitaries said, sir said, what made the conference remarkable was not just its structure or scale, but the spirit in which it was received. And we are thankful to all the delegates. The way you people received is like anything, because it is reciprocity that you people are also smiling towards us and we are also giving a smile to you people. That is our main thing which we are giving and receiving. In the last 2 days, the diversity of the voices from senior faculty to the first time presenters, as you saw that UG, this year conference is witnessing that so many UG presentations which I never seen in this professional experiences, that affirmed our community to growing not only in number but in depth, inclusivity, sensitivity, as the halls of the medical education unit echoed with the presentations, laughters and applauses. We were reminded that forensic medicine is no longer in silent partner in healthcare. As many of the faculty appreciated that from the medicine department, anesthesia department, like it was something which is like bridging the gaps, which was not talked about. And let us leave here not just certificates and photos, but renewed clarity of purpose to uphold the law, not only in courtrooms and clinics, but in quiet decisions we make everyday healthcare professionals. And at the end, I would like to thank Almighty for blessing us with good health and spirit to conduct this conference successfully. I heartfelt gratitude to our chief guest Abhay Nirgule sir, Dean Faculty of Medicine, for the inauguration of the conference, delivering an insightful address and your presence. It matters a lot, sir. I extend my deepest gratitude to our guest of honor. As he said that he is from finance, but yes, his advices made any conferences like at next scale. In that short amount of money, how best you can use it, you can learn from a finance experts. That is why we are very thankful to you, sir. Because of your motivations, we did this. I would thank to all distinguished speakers, panelists and resource persons for sharing their expertise and interesting fact into many domains of forensic medicine. Your sessions have enhanced our insights. I special thanks to all the delegates, forensic experts, academicians, medical officers, researchers and students who came all across the country and gathered here. I also extend my sincere appreciation to the organizing committee, faculty, coordinators, volunteers who tirelessly work like anything, and technical teams, support staff. Each and everyone put this conference remarkable. And I would like to thank our management, our Chancellor sir, Pro-Chancellor sir, Vice Chancellor sir, Registrar, who are not here, but whenever we need it, they are always say, go on. And finally, to every participant and attendees, thanks for being part of this academic journey. May the knowledge gained and connections made here today guide us all a stronger, more effective forensic science and medical legal system in future. Let's meet again soon, and until then, let's keep the spirit of Foryensicon alive in your practice. With that, thank you. Have a nice day. So with this, we'll formally conclude the Foryensicon 2025, and I welcome all the delegates for a high tea outside. National, yeah. Please, before that, we'll raise up for the national anthem.
जनगण मन अधिनायक जय है भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जनगण मंगलदायक जय है भारत भाग्य विधाता जय हे जय हे जय हे जय 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 जय.
Thank you. Jai Hind.